is supposed to work right now.
Okay, which of the following is the most appropriate next step in management? Let's read. 24-year-old woman, gravidarum, pair 0 at 36 weeks gestation, comes to fetal movement have been normal. Oh wait, we already solved that. Right, never mind. Okay. Which was the most appropriate pharmacotherapy? Bedside ultrasound shows 9-week intrauterine twin gestation with 2 fetal heartbeats.
Okay, persistent nausea and vomiting, 3 days. The patient is
Okay, this woman has hyperemesis gravidarum. What? Yeah, to be honest, I shouldn't have eliminated that. I didn't know that. This patient presents with hyperemesis gravidarum, severe form of nausea and vomiting during pregnancy. While nausea and vomiting during pregnancy, typically mild and self-limited, hyperemesis gravidarum is characterized by persistent, intense nausea and vomiting, which can interfere with daily functioning. Other symptoms can include weight loss and dehydration. Okay, she didn't get weight loss, but she's definitely dehydrated and her blood pressure is kind of low. Okay, so risk factors are multiple gestations. She has a twin pregnancy, so that makes sense. Risk factor in first pregnancy, right? She's gravida 1, so first pregnancy. Multiple gestations, a personal or family history of hyperemesis gravidarum. It's dependent on disease severity. Patients who are hypovolemic or have electrolyte require inpatient management with intravenous hydration, parenteral antiemetic therapy, and electrolyte repletion. Normal volemic, have normal electrolytes. Okay. Initial management include dietary modifications, avoiding an empty stomach, eliminating spicy, high-fat foods, sips of fluid, first-line medications. Okay. Alright, so how does that present? Basically, she has persistent nausea and vomiting. She's only able to sip water. She cannot tolerate food for 36 hours. The patient takes no medications. And she has a first pregnancy or double pregnancy. She had like twin pregnancy. Yeah, so which of the following is the most appropriate pharmacotherapy? You give her this drug right here, doxylamine pyridoxine. This is like the first line. You can give her an antihistamine if that doesn't work. Which trimester is that? Like first trimester? Okay, they didn't specify which trimester. So first line, you just give her vitamin B6 plus doxylamine. I don't know what doxylamine is. Mechanism. Okay, so like antihistamine. Yeah. Almost like antihistamine. Doxylamine and pyridoxine. Doxylamine, pyridoxine. Doxylamine, pyridoxine. Okay. We don't use that for sure. That's like cancer antiemetic. Okay, so first line is doxylamine pyridoxine for hyperemesis gravidarum. If that didn't work, diphenhydramine. If that didn't work, metoclopramide. If that didn't work, ondansetron. Wow. Assalamu alaikum, Omar. How are you, bro? Can you imagine I just have to memorize this? It's crazy. I have to memorize that the treatment of hyperemesis gravidarum is number 1, vitamin B6 plus doxylamine, so doxylamine pyridoxine. And then if that didn't work, I give him antihistamine, diphenhydramine. If that didn't work, I give him metoclopramide. If that didn't work, ondansetron. That's crazy, actually. Whatever. Which of the following is the best next step of management? 3-year-old woman, gravida 1. 14 weeks ago, the patient denies pain, bleeding. I had nausea that resolved a few weeks ago. The patient has no chronic medical problems, takes no medication. Yeah, we all have fish memory, bro. The patient denies pain, bleeding, but nausea that resolved a few weeks ago. The patient has no chronic medical problems and takes no medications. Her mother and brother take medication for thyroid disease. Her father has hypertension. Her pulse is 82, 122. Fetal heart rate is 160. That's a high TSH, actually. That's a high TSH, isn't it? Yeah, a little bit high. Normal 0.4 to 4. Yeah, it's 5. She has 5.3. Okay, so I mean, we gotta treat that hypothyroidism. She had nausea. Okay, I think we just don't we don't give methimazole because it's contraindicated in pregnancy, and this is anti-thyroid medication as well. Like, so this is not gonna work. Thyroglobulin antibody testing. I mean, she doesn't have symptoms of hyperthyroidism. TPO, she's 30 years old. She might have Hashimoto. Who knows? Maybe. Expectant management. No, we gotta treat that. Let's see the free thyroxine, the normal one. 5 to 12. That's very low. Oh, sorry. Free 0.9 to 1.7. Okay. You're saying A, administer levothyroxine? 1 second, my brother is. اوكي يعني بعرف بعد ما تخلص عشان اعرف اركز بس. OBS disconnected. Yeah, it's working now. No, now I'm in Buffalo, in New York. Thyroid peroxidase antibodies. It's weird. So TPO is either Hashimoto or Graves. Okay. Let me remember thyroid peroxidase. I think its function is like okay, whatever. It's important in the synthesis of thyroid hormone. Okay, so this is a case of subclinical hypothyroidism, meaning she doesn't have any symptoms of the hypothyroidism, but her TSH is abnormal. So in non-pregnant females, we can just do expectant management, but in pregnant female, we gotta treat the hypothyroidism in pregnant females. It makes sense because the baby needs thyroid hormone, I guess. Okay, thyroglobulin antibody testing is indicated in the management of patients who have well-differentiated thyroid cancer. Be elevated in patients with Graves or Hashimoto. Alright, so I guess we don't do Hashimoto's test because she is just subclinical. Alright. Which of the following tests is most appropriate in this patient? Abdominal ultrasound shows adnexal mass on the right side measuring 3 times 5 centimeters. Bowel sounds were normal. Abdominal examination shows a moderately distended abdomen with no organomegaly. When did she get her last mammography? Maybe this because of ovarian cancer? I mean, her maternal aunt died at age 55 from breast cancer. Her mother has breast cancer. She had breast cancer. So probably she has BRCA1 or BRCA2 mutations. You go E, thyroid function test. Why would you do thyroid function test? She's not presenting with any symptoms though. She's feeling tired with daily activities and has occasional abdominal pain and bloating. I mean, that could be from ovarian cancer. I'll just go with A. Okay, yeah. But I didn't know that CA-125 could actually be used to screen for ovarian cancer. Like, it is that important. You can use it for screening. A baseline CA-125 is it's important for epithelial breast cancer. A clinical presentation of vague abdominal pain, bloating, fatigue, a right adnexal mass, and ultrasound points towards the diagnosis of ovarian cancer. This postmenopausal patient. Okay. Yeah, hereditary. Ideally, patients with hereditary cancer syndromes are screened with a CA-125 level and a transvaginal ultrasound to detect ovarian malignancy early. First step in evaluation of this patient is to perform an abdominal and pelvic ultrasound. Yeah, so BRCA1, BRCA2. Alright. Yeah. Yeah, she can feel tired from cancer too. Okay, what is that? Okay, 16-year-old, 2 weeks of pain during intercourse and postcoital spotting. Patient sexually active with one partner, 10 months, and is using this. Has no chronic medical problems, no previous surgery. Speculum examination shows vulvar and vaginal erythema and scant greenish discharge. I was gonna say this is trichomonas, but I mean wet mount microscopy. So trichomonas is diagnosed with wet mount microscopy. So I'm just gonna go with like treatment of no. Okay, yeah, that's trichomonas. I think this is like the whatever it is. Okay. Yeah, oral doxycycline is for chlamydia. You don't need parental consent to treat for STIs. And this is not like a serious problem. It's not like HIV. You don't have to report it anyway. And this is for gonorrhea, so not A, B, D, or A. Which of the following is the most likely diagnosis? Transvaginal ultrasound shows the endometrial cavity to be thickened by heterogeneous cystic mass. Okay, if the beta HCG is more than 100,000, this is a hydatidiform mole. This is not ectopic pregnancy, so
Gonna eliminate that.
Alright, 12-week sized non-tender uterus. Like, even though she's like 8 weeks ago, she has like 12 weeks size. So this is, but the question here, which hydatidifluoro mole, is it complete or partial? Okay, let's see. Yeah, no embryo, so complete. If there's no embryo. Yeah. If there is any embryonic parts, we would say this is a partial hydatidifluoro mole. Okay, that's an easy one. Administration of which of the following is the most appropriate for this patient at this time? BMI is 32. Blood pressure. Okay, wait. She had an open reduction of femur fracture that was complicated by DVT. Treated with, what's the problem here? Wait, She has antiphospholipid syndrome. She has multiple DVTs. She has multiple abortions, and she couldn't get pregnant. She got a do in vitro fertilization, and she has a DVT. She uses tobacco, so she has high BMI. So this is also a risk factor for her. All right. So which one do we give? She has the blood pressure is. Okay, we gotta give her something like in pregnancy. There's no complaint. She just wants prenatal care. I think we gotta treat her hypertension. That's gestational hypertension. We gotta treat it. Subcutaneous heparin. I mean, I thought she had antiphospholipid syndrome, but no. This is just for prenatal care. Okay, I'll just go with this. What? Patient is at 12 weeks gestation, has chronic pre-existing hypertension pregnancy. I think yeah, beta bio. Yeah, I don't understand what this is about. This patient is 12 weeks gestation, has chronic pre-existing hypertension pregnancy. Defined as blood pressure more than or equal 140. Okay, we know that. In order to mitigate this risk, pregnant patients with chronic hypertension are monitored closely for signs of complications. Wow, I didn't know that you give low-dose aspirin to treat to reduce the risk of preeclampsia. Wow, that's new to me. Low-dose aspirin to reduce the risk of preeclampsia. in patients with chronic hypertension. Wow. Low dose aspirin preeclampsia. When is that? 2018. Same. What is the mechanism? I don't know. Maybe people with hypertension have more susceptibility to develop like thrombosis. I don't know. I mean, hypertension causes endothelial damage, so this will increase thrombosis. So if you give low dose aspirin, you'll decrease thrombosis. That's just a okay. Let's ask ChatGPT. Yeah, this is just AI. AI stuff. Okay, never mind. Additionally, low dose aspirin is administered to reduce. Alright, so the question here, how did we know that she had hypertension before the pregnancy? Let me see. She's gravida 2, 12 weeks gestation. Her first pregnancy ended in a 13-week spontaneous abortion. She had an open induction. Yeah, why didn't we just diagnose her as gestational hypertension? I don't understand. Oh, because less than 20 weeks. Oh, my bad. Yeah. She's 12 weeks gestation. She's less than 20 weeks. So, if she's less than 20 weeks and she has hypertension, that's chronic hypertension. That's not gestational. Yeah. Okay, that's weird. Instead of treating their hypertension, we're just gonna give her low dose aspirin. That makes perfect sense, actually. Why is B wrong? Antihypertensive medications are reserved for patients with chronic hypertension who have severe range, so more than 60 or 160 over 110. All right, that doesn't make sense, but whatever. Okay. What's that? Is that answered? Let's read. An ultrasound shows a cephalic presentation, normal fetal movement, tone, placental tissue covering the cervix. Oh yeah, that's placenta previa. Just yeah, that's easy one. Thank God they didn't screw up the question. When you have placenta previa, you just give Mubarak Habibu Habib. Microscopic evaluation of the vaginal discharge is most likely to show which. Okay, fishy odor, pH more than 4.5, and that is easy. Is that trichomonas though? Yeah, that's trichomonas. Okay, so yeah. Oh, wait. The fishy odor, is it trichomonas or bacterial vaginosis? I forgot. Gotta review some micro. Okay, so treatment, yeah. So I guess this is like the table provided by UWorld. Okay, yeah. Oh, yeah. So trichomonas is green. I always mix these two. So it's green discharge, but this is off-white or gray bacterial vaginosis. Even though bacteria seems like to be more like dangerous, can cause green, pus and stuff, but no, it's trichomonas, trichomoniasis. pH more than 4.5. Bacterial vaginosis, off-white. Yeah. The positive whiff test is actually vaginosis, bacterial vaginosis. Alright, the fishy odor is bacterial vaginosis. And there's clue cells, the epithelial cells that have the coccobacilli or the coccobacilli surrounding it. Okay. My bad. I'll mark this question. Alright. Which of the following is the most appropriate next step in management? Alright, let's see. So, evaluation of infertility. Okay, yeah. Alright, now I'm not going to get this wrong. I studied infertility well. She has been unable to conceive despite unprotected sex for 6 months. Right, 6 months is not enough. You gotta have at least a year. She's 24, so she's younger than 35. Okay, I thought we're gonna give her some time. Whatever. Her husband has a son from previous marriage. Okay. Her last menstrual cycle was 8 days ago. They're regular, cramp-like pelvic pain that begins 2 to 3 days before menstruation, which continues until menstruation stopped. She reports pain during sexual intercourse for the past 10 months. Her BMI 22. Vital signs notable for an absence of distension, palpable masses or areas of tenderness. Speculum examination reveals no abnormalities of the cervix and vaginal wall, and by manual examination, a tender uterosacral and rectovaginal. Uterosacral and rectovaginal nodule are felt. What the hell is that? Rectovaginal nodule. Rectovaginal nodule. Okay. Gonadotropic GnRH analogs. No, she's menstruating fine. She has normal menstruation. Yeah, it's cramp-like pain, but whatever. NSAIDs with hormonal therapy. I don't think she needs hormonal therapy. She's menstruating. every 29 days. Alright, let's leave this. Surgical resection during laparoscopic evaluation. I think it has to do with the nodule. It gotta be with the nodule. I don't know what was that. Maybe it's a pocket or something, or like the rectocele or endometriosis. The cyclical pain. Yeah, so the treatment is C then, right? Surgical ablation, like the endometrial ablation. Transvaginal ultrasound. Transabdominal ultrasound. Are we gonna confirm it's endometriosis, or we're just gonna treat it? Transabdominal ultrasound. Okay, let's go with C. Yeah, you're right. It's endometriosis. Good job. Patients exhibiting signs and symptoms. All right, so we gotta confirm it's there first. Would be the appropriate therapeutic option. However, before doing a laparoscopic evaluation, a transvaginal ultrasound is required to obtain details about the location, size, and depth. Okay, we gotta confirm it's like before we remove it, we have to do some imaging first. Okay. But I didn't know which one to pick. Should I pick transabdominal or transvaginal? Okay, let's see. Is it actually clear cut like that? Imaging. Okay, so we actually use transvaginal or transrectal ultrasound. Transvaginal or transrectal ultrasound. Okay, was it that easy, guys? Really? Like everyone is saying endometriosis. So would it cause infertility because of the adhesions it causes, or what? Yeah, right. This is how it causes infertility. Fallopian tube into the pelvic and abdominal cavity. It's typically seen in the 3rd and 4th decade of life, and common for patients to be asymptomatic and diagnosed during abdominal surgeries. The following are the common symptoms: infertility. Endometriosis is one of the most common causes of infertility. Dyspareunia, painful sexual intercourse. Okay. Dyspareunia, dyschezia, painful defecation. Abdominal pelvic pain that typically increases 2 to 3 days before menses commences. Uterosacral tenderness or nodule. Okay, I didn't know that one. Okay, let me type it on Google. Let's see if that's like a buzzword. Recto vaginal nodule. Yeah, so it's endometriosis. All right, so transvaginal ultrasound is the first line imaging, and then we confirm it by laparoscopic evaluation, and then we do surgical resection. We cannot give her oral contraceptives because she wants to get pregnant. We can use that to treat if she doesn't want to get pregnant. We can use OCPs. Yeah, combined in individuals who do not wish to conceive. NSAIDs would be fine, but because with hormonal therapy, so it doesn't work. All right, which of the following presentations describe the presenting twin? A sterile speculum examination shows a fetal foot protruding through the cervix. Okay. Leukorrhea and diamniotic because of contractions that began just after a large gush of fluid. Patient's other pregnancies ended with spontaneous vaginal deliveries at term. She takes daily prenatal vitamin. Okay, so I think that's incomplete breach, right? What's the difference between frank and complete breach? That's not shoulder, I guess, right? Frank breach, he would have his two like legs like that. So he has his legs like falling out of the compound. Complete. All right, let's go with incomplete. Okay. Yeah, so that's Frank. That's what I know it. Complete, then he has like, okay, he has his legs like that. Incomplete, he has his legs out. All right. Fetal presentation, fetal parts closest, breech presentation. What is compound though? Fetal arm or head alongside the head or buttocks. This fetus. His foot has prolapsed with the cervix at its presented part. Yeah. Okay. That's compound. Which of the following genetic conditions is the most appropriate test to test for in this patient? Okay. Transvaginal ultrasound shows an 8-week intrauterine pregnancy with normal fetal heartbeat. Which of the following genetic conditions is the most appropriate in this patient? All right. She works as a youth director for her church. That's weird. I have no clue. Okay, so I think we just got a screen for cystic fibrosis in all women. Universal cystic fibrosis screening for all couples planning to conceive and all pregnant women who have not previously been tested. The optimal time for CF screening is prior to pregnancy so that parents who are CF carriers and are at increased risk of a child with CF can be counseled regarding reproductive options. CF screening during pregnancy identifies women with fetuses at risk for CF. Okay, we just screened the patients.
Yeah.
All the patients were cystic fibrosis. And also for hemoglobinopathies. So why don't we pick thalassemia? Why isn't E right? Okay, yeah, she has normal hemoglobin. Alright. Normal hemoglobin and normal MCV. That's good. Okay, wait. Yeah. Which of the following is the most likely? Okay, so let me just memorize these. They're gonna come up. Spinal muscular atrophy, so that's SMN1. Cystic fibrosis, hemoglobinopathies, so sickle cell disease, thalassemia. Alright. Which of the following is the most likely cause of this patient's ultrasound findings? Which of the following is the most likely cause of this patient's ultrasound findings? Alright, 24-year-old gravidarum, 32 weeks gestation, comes to the physician for routine prenatal visit. Unsure of her last menstruated. Patient had flu-like illness during her first trimester. Takes daily prenatal vitamin. Symphysis pubic fundal height is actually low. So normally you have the same number of weeks is equal to the symphysis fundal height. The fetal heart rate is 150. Ultrasound shows a fetus in vertex presentation. Fetal femur height, length and abdominal circumference are both under the 1st percentile. The head circumference is at the 14th percentile. Fetal weight is at the 5th percentile. So the following is the most likely cause. Patient's ultrasound findings. Zizo, Eid Mubarak عليك حبيبي. I miss you يا عم. فينك? Where are you, bro? تعالى شوفني. I'm getting screwed in OB-GYN. I know nothing, bro. Do you have any recommendations for OB-GYN? I mean, I'm getting it right now. I'm getting some mistakes in, and I'm trying to learn. Yeah, like video recommendations. Yeah, that explains stuff and breaks stuff down for people who don't know anything about it. Old Kaplan OB-GYN 2007 videos. Dr. Elmar Sakala. Can I watch it on stream? It will be copyright strike. Okay. I don't know if I'm gonna get copyright. Okay. I'm definitely gonna watch these series. I'm getting all the OB-GYN questions wrong. It's crazy. Look. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. That's half of the block is wrong. Oh, okay. So, yeah, let's do it, bro. Okay. I know, getting mistakes, teaches you and stuff, but I just wanna, see progress, So, okay, let's solve this. Which of the following is the most likely cause of this patient's ultrasound findings? 24-year-old, 32 weeks gestation, just prenatal visit. So, unsure of her last menstrual period and her pregnancy. Okay, what I got from this is that her symphysis fundal height is 28, and she's 32 weeks gestation. So, that's not good, right? That's just bad, I guess. Ultrasound shows a fetus in vertex presentation. I guess that's normal, right? Fetal femur length and abdominal circumference are both under 1st percentile. I guess we're just that, isn't it? The head circumference is 14th percentile, so he has, what is it called? Microsomia? No, microcephaly. Microcephaly. And the fetal weight is 5th percentile. I don't know if that's rubella or whatever. But he doesn't have any heart problems or whatever. The fetal heart rate is normal. I think it's just uterine placental insufficiency. What do you think? Incorrect dating? No. I mean, it's evidenced by the fetal femur length and abdominal circumference, so I don't think that's correct. Fetal chromosomal abnormality. She's 32 weeks gestation. I mean, it would present with like abnormal symptoms or abnormal signs more than that. B&B for step 2 and Melman videos are amazing. For OB-GYN, you mean? Yeah, the problem is I didn't go through the OB-GYN. Let's see if it's insufficiency. Listen, incorrect dating is the most common error, by the way. Really? No way. He has like head circumference is low, and fetal weight is 5th. It can be incorrect dating, right? Am I right? So the problem I didn't go through is also common reason for babies being very small. I mean, look, he has normal anatomy. He gotta has like he gotta have. Yeah, I'm Arabic. I'm Egyptian, but I live in Buffalo now, in New York. Okay, let's see if uterine placenta sufficiency is correct, because he has normal anatomy, so that's a reason why it's not B, right? Constitutional smallness. I don't know what the hell is that. Let's go with E. Okay, that's good. This patient shows the fetal femur length and abdominal circumference less than 1 first percentile. I'm biparietal perimeter. Okay, fetal growth restriction. In symmetric fetal growth restriction, the head and abdominal circumference are equally affected. Thanks, bro. I got it with your help, man. In asymmetric FGR as seen in this patient, the abdominal circumference is more severely affected than the head. I didn't notice that at all. In symmetric FGR, the head and abdominal circumference are equally affected. In symmetric FGR, the head and abdominal circumference. Yeah, okay, that makes sense. It's less than 1 percentile, but this is like 5th percentile. Less than first percentile, and this is less than 5th, and less than 14th. So yeah, the abdomen and female length is affected more. Asymmetric FGR occurs when maternal medical comorbidity or placental disorder leads to chronic suboptimal placental perfusion, uterine placental insufficiency, and chronic fetal nutrition. In response, the fetal blood flow shifts away and towards organs. Okay, yeah, it makes sense. Yeah, so he has the blood shifted towards the brain, so that's why the head circumference is not as severely affected. FGR refers to an ultrasound estimated fetal weight that is less than 10th percentile for gestational age. There are 2 types of FGR. Alright, which of the following is the most likely cause of this patient's finding? Microscopic evaluation of the discharge shows rare PMNs and abundant squamous cells and 10% All right. 3 days of vaginal discharge. What is the color? I can try Boards and Beyond, but it's copyrighted, so I don't want to get a copyright strike. So I can't watch it here on stream. So I'll check the Kaplan videos of OB-GYN to like become better, I guess. The patient has no current. So checks sexually active, has multiple partners. He's not okay. Devoid of edema, erythema, papules. Speculum examination shows copious, white, odorless, mucoid vaginal discharge. She doesn't have PMNs, so it's not bacterial vaginosis. It's gonna be green discharge. Gonococcal. I think you'll have a lot of PMNs. So physiological leukorrhea. No. She wouldn't have all these like symptoms. No edema, no erythema, no papules. I think that's just, yeah. Oh wait, no way, bro. What? Wait a minute. Oh, I thought she's complaining of pruritus. Oh, she's complaining of just discharge. Okay. Discharge, that's it. She's complaining of discharge. She has had such discharge frequently over the last few months and mentioned that it usually returns after the end. It's her normal secretions. That's her being wet. Okay. Yeah, bro, but like I thought she said they said pruritus. Copious white, odorless, mucoid vaginal discharge. Is indicated by an odorless that is thick and cottage cheese-like. Okay, so I guess because it's not cheese-like, then this is an association with vulvopruritus. Yeah, I know that. And erythema distinctive findings of. Okay, so potassium hydroxide wet mount is used to test for Canada. Yeah, primary concern regarding copious amount of white vaginal discharge. ضحكتني bro. Vaginal discharge hints at a possible diagnosis of physiological leukorrhea, which is most evident mid-cycle around 10 to 14 days after the end of menses. And is associated with increased estrogen stimulation seen before ovulation. Okay. After the end of her menses, is that mid-cycle? Or like at the end? Wait. Is that mid-cycle or what? I think I have. That's after her period, yeah. Bro, that's weird. Wait, period is like the day 14, like in the mid of the month or the end of the month? I feel like I have a stroke or something. Yeah. 14 days. Shit. Yeah, 14 days, and then she has the menses, and then she has. Thanks, Eunice. I appreciate it, bro. Thank you.
Okay, follicular phase, luteal phase. Menstruation, 6 days, and then ovulation, and then luteal phase. Damn, yeah. I thought, for some reason, my brain told me
no period is the start/end. That's your period, aka bleeding. That's where a new cycle starts. Yeah, for some, even though I know that the period is every 1 month, for some reason I thought it's every 14 days, like an idiot. But yeah, you still have the luteal phase, which is gonna last about half a month. And if she got pregnant, she's not gonna menstruate the next month. Yeah. My bad. I had a stroke. Okay, so after the end of her menses, yeah, that's mid-cycle. Okay, that makes sense. After the end of her menses, that's mid-cycle. Her last period ended 9 days ago, and she came complaining of discharge. Okay, so 3 days to 6 days after her period mens, so like day 20, she came complaining of the discharge day 20. So it starts mid-cycle, but how long does it last? So often mid-cycle around 10 to 14 days after. Oh, okay. Mid-cycle around 10 to 14 days after the end of menses, associated with increased estrogen stimulation seen before ovulation. This odorless discharge, which is typically about. Okay, normal vaginal flora, squamous epithelium, and cervical mucus. Other signs of infection like pruritus, pain, not seen cases, although this patient's presentation is consistent with physiological leukorrhea. In addition to clinical evaluation, the definitive determination of the etiology of the vaginal discharge should include wet mouth microscopy. Okay. All right, I got that. Yeah, at the end of menses, which is like right here. Yeah. Mid-cycle. Proliferative phase, then secretory phase. Yeah. Okay, let's move on. Which of the following is the best contraceptive method of this patient? Okay, I got a lot of these questions, a lot of similar questions, so I'm not going to get this wrong. 24-year-old woman, Gravida 2, comes to the physician for contraception management, although she has not decided yet whether she wants to have more children later on. Has not decided yet. Okay, menses occurs monthly and consists of 7 days of heavy bleeding. Patient has history of 2 cesarean deliveries, both for breech presentation, uterus didelphys. She has no chronic medical problems and is taking a daily multivitamin. Okay. So she has heavy bleeding. We don't want to cause more bleeding, so we're not going to give her copper IUD because this contains more bleeding. The cycle starts by shedding. Yeah. For some reason, I thought the menses is in the middle. For some reason, I don't know why. Like in my head, I thought the menstruation happens in the middle of the cycle. I don't know why, but that's wrong. So the menses happens in the end of the month. Yeah. Okay. Yeah. Disadvantages of being a male, I guess. Bimanual pelvic examination is normal. Which of the following is the best contraceptive method? Bilateral tubal ligation, no, because she has not decided yet. Combined oral contraceptives, I think so, because she has heavy bleeding. Etonogastrial subcutaneous implant. No chronic medical problems. Taking a daily multivitamin. Levonorgestrel containing IUD. Wait, Gravida 2, Para 2. Yeah, okay. Etonogestrel subcutaneous implant. History of 2 cesarean deliveries. Thanks, bro. I'll download it now and watch it. I really need that stuff. Okay, I got it wrong again. Okay, why is it not E though? That's crazy. Abnormal, distorted. Okay, that's shit. That's because she has like a weird uterus. Oh, okay, that makes sense. Because in this case, we're gonna give her like, yeah, we're gonna give her 2 IDs, like for each uterus. Okay, that makes sense. Oh no. Okay, so this one and this one is out of the way. You only have B and D. So why it's not combined oral contraceptives? However, they are second-line contraception method generally reserved for patients who have contraindicated to long-acting. Okay. And don't give her estrogen. Why wouldn't you give her estrogen? She's 24. Contraceptive choice is a complicated process that takes into consideration the reproductive goals, preference, the presence of comorbidities and complications, as well as the characteristics of non-contraceptive benefits of the various contraceptive methods. Long-acting reversible contraception is the most effective reversible contraception available and includes the copper-containing IUD, this. Okay, long-acting reversible contraceptive is the most effective reversible contraception available. Okay, I know that. I know that the IUDs are the most effective. But not only the IUDs are considered like under LARC, also the etonogestrel containing subcutaneous implant is not dependent upon the patient compliance for efficacy. It is characterized by rapid return to fertility and doesn't require the use of exogenous estrogen. Therefore, bro, I'll go sleep. It's 1:30 p.m. and tomorrow I'll do an MBME. Let you know how it went. Yeah, bro, update me. Good luck. Estrogen increases risk of VTE and bleeding for her. I mean, there's no estrogen here at all. So you have B, combined oral contraceptives, which is both estrogen and progesterone. So you're not gonna cause unopposed bleeding. Although there are few contraindications to LARC, distortion of the endometrial cavity, either from congenital anomalies, intrauterine adhesions, and leiomyoma is a contraindication to the IUD. Therefore, the best contraceptive method for this patient who has uterus didelphys is the etonogestrel containing subcutaneous implant. Okay, I gotta finish that shit quickly. I only finished like 40 questions today. I have to finish another block. So I gotta move faster. Long-acting reversible contraception is the most effective contraception method available. It's considered first-line contraception for most patients. LARC methods include the copper IUD, this and this. Okay, so IUD use, it's contraindicated in patients. Copper IUDs are contraindicated in patients who have bleeding, heavy bleeding, because it causes more bleeding. IUDs are contraindicated in patients who have like urine distortion. So they have congenital anomalies, leiomyomas, whatever. Okay, let's move on. Bismillah. Which of the following is the most appropriate next step of management? Okay, 40 weeks gestation, has an uncomplicated vaginal delivery. The woman is Rhd negative but did not receive the ROGAM. An antibody screen from the time of her admission is negative for anti-Rh antibodies. If she's negative, I think we're gonna do the Rosette test. Wait, she's negative, but she didn't receive the ROGAM. Okay, we gotta determine the infant's blood type. Bismillah. Thank God. Okay, I got like 10 questions like this wrong before, so I know the game now. Where's my phone? My phone is ringing. Oh, here it is. Okay. All right, so we have to make sure that this patient is Rh. We have to know what's his blood type. If he is blood type Rh positive, we're gonna do the Rosette test. If he's like Rh positive, if he's Rh negative, that's done. We don't need to do anything. So first step is to do an antibody screen. If he's negative, she's negative, she doesn't have any antibodies, let's know the fetal blood type. Because if he's positive, Rh positive, we're going to do the Rosette test to determine if the patient got any blood to like any blood, any fetal maternal hemorrhage. That's like the qualitative test. And then we got to do Howard-Betke test, which is the quantitative test for fetal maternal hemorrhage, and that's the quantitative test. So if it's less than 30, you're gonna give her a 1 vial of anti-ROGAM. If she's positive, you're gonna give her more than 1 vial. So you're gonna give her a vial anyway if she has fetal maternal hemorrhage. Yeah. Okay, got this. Which of the following is the most likely diagnosis? This is... Okay, that's weird. This is higher than this. Okay, 19-year-old comes to the emergency department because she noticed some blood on her underwear after experiencing a fall down the stairs. So she fell. She reports no change in the amount of bleeding and fall. She's associated with crampy abdominal pain. She admits to using cocaine since the middle of her second trimester. On examination, her temperature is 37. On abdominal examination, the uterus appears to be at the level of the xiphoid process and is uniformly stone hard and tender. Okay. Continuous mild vaginal bleeding is observed and the vaginal examination is deferred. A non-stress test is shown. Continuous mild vaginal bleeding. Okay, is that a... Okay, we have veal chop. Veal chop. Veal is variable decelerations. These are not variable decelerations. Veal chop. Early decelerations. These are not early. Accelerations. These are not. Okay, that's fine. Late decelerations. Placental insufficiency. I don't know, to be honest. Oh, her blood pressure is 164. Huh, that's lucky. I got it lucky. The correct answer is C. This patient likely has placental abruption. Placental abruption is known as abruptio placentae. Is the detachment of placenta from the lining of the endometrial cavity prior to the delivery of the fetus. Common risk factors include teenage pregnancies, recent abdominal trauma, hypertension, exposure to smoking, alcohol, cocaine, previous history of okay, I want to see what is the stress test says. What does the stress test say? Fetal heart rate will typically show a late deceleration on non-stress test due to placental insufficiency. Okay, so this is late okay, that makes sense. Let's see what's the normal non-stress test looks like. Non-stress test. Okay, where is it? Okay, so it's directly above. See? This is directly above. Oh, this is late. This is late deceleration. This is... Wait, is this early deceleration? What's the normal? Where's the normal one? Need help here. Non-stress test. Okay, so okay, so the deceleration before like the contraction, right? Oh, I need help, guys. So that's the beginning of the contraction, and then it dips like that. Normal non-stress test. Okay, here's the contraction. The onset. Gradual decrease in FHR with onset of deceleration. Wow, so you actually should like get some time before you get the deceleration. You still have like a little bit of time before, like here, uterine contraction. Okay, I'm gonna use Kaplan for this, like Kaplan videos, to understand that shit. Okay. So this is early deceleration, I guess. Early. I don't know how that is early. Late, sorry. Yeah, that's late. That's late deceleration. So that's that. That's late deceleration. If anybody can explain this to me, I'll be happy. Okay, so I knew that this. I just guessed that this is late deceleration, and the cause of late deceleration is veal chop. So, placental insufficiency. So, what is the cause of placental insufficiency of this? So, eclampsia, she doesn't have fever. She doesn't have seizures. Right? They don't have, like... Sorry, guys, my brothers are here. Placental abruption. Alright, I got this. Which of the following aspects of this patient's presentation is the strongest contraindication to the vaginal delivery? Okay. So a bedside ultrasound shows a breech infant with no fetal heartbeat. Contraindication to vaginal delivery? I think breech presentation. Yeah. Nice. Prior classic cesarean delivery. Oh, okay. So because when you use classic cesarean delivery, you cut the muscles of the uterus in a way that the uterus cannot contract anymore, or it's gonna rupture. Okay, yeah, that makes sense. All right, types of C-section. Types of C-section. So you have vertical, T, and horizontal. What is the classic? Yeah, that's the classic one. You can't do that. This is dangerous. If you did that once, you can't use vaginal delivery. Yeah, I know that one. I thought breech presentation is just you're gonna do C-section. Although breech presentation is a contraindication to vaginal birth, including VBAC. What is VBAC? Vaginal birth after okay. Although breech presentation is a contraindication to vaginal birth, including in most fetuses due to a risk of fetal injury, it's not a contraindication. Oh, endomyosed fetus, because you're not worried about the fetus; it's already dead. Oh man. Alright, that's the importance of looking at all the answer choices. Because it's just is what it is. Because he's dead, so okay, whatever. Which of the following is the most appropriate next step in management? Which of the following is the most appropriate next step in management? Transvaginal pelvic ultrasound shows a thickened endometrial stripe. An endometrial biopsy shows endometrial hyperplasia. Okay. Speculum examination shows scant blood in the vaginal vault and normal cervix. Several weeks of vaginal spotting. Takes metformin for type 2. Okay, I'm dazing off right now. Patient was prescribed tamoxifen for breast cancer due to strong family history. Uh,
لا مش بتكلم على كده، بس المشكلة اللي انت ساعات
oh, what is the treatment of endometrial hyperplasia?
بتدعم حاجات بتدعم زي دي مثلا.
She's 56, so this is dangerous. Yeah, Amir. No. Oral progesterone supplementation, leave-in or gestral containing intrauterine device. Hysterectomy? No. Oh, wait. Breast cancer convention due to strong family history. Menopause at 8. Yeah, I think that's what I mean. She has a strong family history. She's probably BRCA1 or BRCA2 positive.
الجواز التاني
Uh,
حاجات تدل عليها في الجواز لما بنسخن تحس
it's also probably because of tamoxifen that she took.
برضه حاجات كتير بس
It's an estrogen antagonist at the uterus. Sorry, at the breast. Okay, let's go with this. I'm not really sure, but let's go with this. Okay, I was right. Tamoxifen, a selective estrogen modulator, acts as an estrogen antagonist in breast tissue and decreases the risk of estrogen receptor positive breast cancer in women who are high risk. Tamoxifen is an estrogen agonist in the uterus, leading to an increased risk of abdominal uterine bleeding. Yeah. Patients who develop abdominal uterine bleeding while on tamoxifen, postmenopausal who develop endometrial while taken, require a total abdominal hysterectomy because of increased risk of cancer. Okay, that's weird. I thought we removed that because she had a strong family history. Tamoxifen is a selective estrogen receptor modulator. Therefore, although patients with endometrial hyperplasia who are not taking tamoxifen can be treated with
هشام، هو انت رحت الابوينتمنت بتاع الدكتور اللي هي دكتور النعمان ده؟
okay, maybe it just increases the risk so much they have to remove it. Alright, so patients who are on tamoxifen that develops endometrial hyperplasia, you gotta do a biopsy. If she develops abnormal uterine bleeding, you gotta do a endometrial biopsy and pelvic ultrasound, and then you gotta remove the uterus and yeah, so why did we remove, like, wait a minute. All right. Okay, we're done with this block. And block. Okay, that is shit. That is garbage.
That is garbage. Okay. Let me actually download the videos. 1 second.
Okay, so I'm gonna download. Wow. Damn. Kaplan videos are 18 chapters? No way, bro. No way I'm gonna watch this. Holy. What is that, bro? Okay, that is obstetrics. What is that? Okay, that's obstetrics. That is gynecology. Yeah, that's gynecology. Okay, let me save this. Okay, I'm gonna watch the things that I'm weakest at. I'm weakest at obstetrics more than gynecology. Okay, so alright, so that's about like 11 minutes, 38 minutes. That's about like 3 hours, just one chapter. And this is about, oh no. Okay, some chapters are very small, and some chapters are very long. Okay, let me, I don't know what to do, to be honest. Let me finish all the questions of obstetrics and gynecology before even attempting to watch videos, because that's the correct thing to do. So tutor mode, 40 questions, obstetrics and gynecology. Yeah. Okay, let's do that. I have 129 questions left. Okay, I'm gonna visit the bathroom and come back.
All right, so I'm gonna actually I have a very bad week, like a serious weakness when it comes to OB-GYN, and the reason being is I didn't go through the classes in med school. I used to like skip them for, and go have breakfast. So what I'm gonna do is I'm gonna strengthen my foundation to just prove that even if you didn't attend a specific class in med school, you can still ace it, right? When it comes to STEP. I solved about 80 questions OB-GYN till now, and I realized I have a serious weakness in it. I got most of the questions wrong. So what I'm gonna do is that I'm gonna go through the entire Kaplan videos. I'm not gonna watch them, like just watch them. I'm gonna have a copybook beside of me. I'm gonna go through the classes again, right? Probably it's gonna take me like 4 days or something, but I'm pretty sure if I got this, I'm gonna show you something. So here are my test, like my basic. When I do random questions, here's my scores, right? Here's my scores. Okay, I don't know why it doesn't want to open. Damn, bro. I can't show you my my scores. Just want to show you something. Whatever. So I'm scoring random in like 70s, right? I'm getting 70, 75. That's random. And most of my questions are actually OB-GYN and surgery. So I've done the surgery part. I understood a lot of concepts in surgery. The reason I'm getting like these problems is that I mastered step 1 very well, but in OB-GYN, you don't have any OB-GYN in step 1, maybe a little bit of gynecology, but you don't have any obstetrics. Same thing with surgery. You don't have a lot of surgery concepts in step 1. So I have no idea about these subjects at all. In addition, like I didn't do well in them in med school. I told myself I'm never gonna be a gynecologist or OB-GYN doctor, so there's no way, there's no reason to be good at them, and that's why I just didn't go to class. Anyway, so I'm very like persistent on showing you guys my scores, but okay, you know what? And never mind. So here's my plan for OB-GYN. Okay, I'm gonna do that as a challenge to myself, and for those of you like to get motivated. I finished 40 questions today. I'm gonna finish another 40, and I have a coffee here, so I'm gonna drink a lot of caffeine to just wake up for a while, and I'm gonna finish as much videos as possible, and I'm gonna gather as many notes as like in my head as possible. I'm gonna understand everything, and I'll see my score after. So I have about 129 questions left. I'm gonna finish 40 questions right now. I'm gonna study OB-GYN from Kaplan. I'm gonna finish the rest of the 69 questions, and see like where I'm standing. Okay, so I hope that sounds like a good plan. All right, let's do this. Which of the following is the most appropriate prenatal genetic test to confirm the diagnosis of Down syndrome? Which of the following is the most appropriate prenatal genetic test to confirm diagnosis of Down syndrome in this fetus? Okay, so I know there is amniotic villus sampling, I know there's chorionic villus sampling, and amniocentesis. Depending on the week, so she's 10 weeks, that's less than 15 weeks, so that's chorionic villus sampling. To confirm, if you want just a screening tool, you can do this. Okay, I was right. I memorized that part. So chorionic villus sampling is less than 15 weeks. She's 10, so less than 15. All right, and then more than 15 weeks gestation, then you have like amniocentesis. So
So either screening or confirmatory diagnostic, like screening diagnostic. For most patients, prenatal genetic testing is initiated with a screening test in pregnant women who have risk factors for genetic abnormalities, prior pregnancy complicated by genetic abnormality. For most patients, prenatal genetic testing is initiated with a screening test in pregnant women who have risk factors for genetic abnormalities, prior pregnancy, complicated by genetic abnormality, whatever. CVS offers okay, so let me just make sure that this is a screening test. Yeah, quadruple marker test and cell-free DNA testing, both of them are screening tests. They do not help confirm the presence or absence of Down syndrome in the fetus. Patients who require termination after amniocentesis are limited to second trimester termination, which is a more complicated procedure than a first trimester termination. Yeah. That is also screening, by the way, nuchal transfer surgery. At the age of 12 to... Okay. There's a lot of memorization here. Let's, oh, no, bro. Come on. What the hell is that, man? Okay, this error comes a lot. A lot of times you got this error here. Sometimes it doesn't even work. Oh no, my plans. Okay, I'm gonna watch a video, like chapter 1 here. Gonna start from obstetrics. Okay, let's go. Bismillah. All right, let's see this. Let's add a new folder. Obstetrics, Kaplan. Physiology of reproduction. Let's do this. Oh wait, oh sorry, I already downloaded it.
Welcome to the second section of obstetrics and gynecology, and this is the section on obstetrics. We'll start out chapter 1, reproductive basics. And we will begin with physiology of reproduction. The pregnancy hormones are going to be the first topics that we're going to talk about. And these are really important. We have the placental HCG, human chorionic gonadotropin, HPL, which is human placental lactogen, progesterone, and then estriol. HCG is probably the most important one that we think about. Because it is the basis of the chemical pregnancy test. Now, when I was a resident and a student, We did not have a beta HCG. All we had was HCG, and there's a lot of cross-reactivity with FSH, with LH, and with TSH. But nowadays we have the beta subunit, which is unique and specific for pregnancy.
Yeah, that makes sense. This is the structure of HCG versus LH. That's a step one stuff, I know that. So there is a, yeah, so there is, this is LH, this is how it looks like. There's alpha and beta subunit. This is alpha, beta, alpha, beta. So the different part is the beta. That's why we use it. If you just use HCG, like the entire molecule, it's gonna look very similar to LH and FSH. So that's why we use beta.
If you have a negative beta HCG, you can exclude any viable trophoblastic tissue. Let me give you an example of how important this is. What is your next step in management with secondary amenorrhea? Beta HCG. What is your next step in management if you have abnormal bleeding in the reproductive years? You've got to think of some pregnancy complication. Now the patient may say, but doctor, there's no way I could be pregnant. Right. Next step in management, beta HCG. Patient in the reproductive years comes in with lower abdominal pelvic pain. What should you think of? Ectopic pregnancy. Next step in management, beta HCG. Patient comes in the reproductive years with a pelvic mass. What's the most common cause of a pelvic mass in the reproductive years? Pregnant uterus. Next step in management, beta HCG. Enlarged uterus. What's the most common cause of an enlarged uterus in the reproductive years? Beta HCG. You get the idea? Beta HCG. Every patient that is on the step 2 exam, you should think, could she be pregnant? Now there's childhood, pre-puberty, we have puberty, reproductive years, menopause, postmenopause, but always think when there's a female patient, could she be pregnant? Beta HCG. Okay, this next slide shows where is beta HCG produced, and you can see here it is produced by the syncytial trophoblast cells. The trophoblast, remember, has an inner layer which is the cytotrophoblast and an outer layer which is the syncytial trophoblast.
We're going to increase the speed a little.
Once the invade the maternal sinusoids, we now will have beta HCG in the mother's circulation. That usually occurs in the second week post-conception. Now on the exam, they've had a question, what is the gestational age with the peak of beta HCG and the plateau? And you can see here that beta HCG peaks in the first trimester. The peak is around 9 to 10 weeks, and it levels off, as you can see here, at about 20 to 22 weeks. Now, the importance of this is that a beta HCG, which is normal in the first trimester, may not be normal in the second trimester. And remember, the cases where you have a high beta HCG is molar pregnancy. We'll talk about that with trophoblastic disease. So it peaks at 9 to 10 weeks and levels off at around 20 to 22 weeks. Now, what should happen to normal beta HCG values in the first trimester? Well, they obviously go up. What happens every 2 to 3 days? They should double. So if you got serial beta HCGs, here's what should happen on successful pregnancies. The level rises. And this is one way of at least giving a reassurance that the pregnancy is normal. If a pregnancy is not normal, what will happen to the beta HCG values? And here you can see they will be falling. So beta HCG is one way of assessing the viability of a pregnancy in the first trimester.
Wow.
All right, following a reassurance beta HCGs, here's what should happen on successful pregnancies. The level rises, and this is one way of at least giving a reassurance that the pregnancy is normal. If a pregnancy is not normal, what will happen to the beta HCG values? And here you can see they will be falling. So beta HCG is one way of assessing the viability of a pregnancy in the first trimester.
It makes sense because beta HCG, it goes to the corpus luteum and stimulates it so that progesterone is secreted. And progesterone is responsible for maintaining the endometrium to preserve the endometrium to support the pregnancy.
The site of production, we already talked about that, is in the syncytial trophoblast tissues. And again, I would emphasize, if you have a negative serum beta HCG, you have no viable placental tissue. What is the purpose? In the first part of the pregnancy, it is to maintain the corpus luteum. Now, the corpus luteum, remember, produces progesterone. And if there is no progesterone, or if the progesterone starts to fall, you're going to have spiral arteriolar spasm, you're going to have necrosis, release of prostaglandins, and you're going to have shedding off of the endometrium. In order to maintain the site of implantation and the normal pregnancy, you need to have continuation of the production of progesterone by the corpus luteum. The beta-HCG is what signals to the corpus luteum you need to continue producing progesterone. Now, many pregnancies where there is concern about a corpus luteum deficit, patients will be put on vaginal progesterone suppositories. How long do you need to continue those progesterone suppositories? Well, the placental would take over between 8 to 10 weeks. So after 10 weeks, you don't need to give the progesterone supplementation anymore. If you have very high levels, you could have a twin pregnancy, and we just talked about a hydatidiform mole. If weeks, how long do you need to continue those progesterone suppositories? Well, the placental would take over between 8 to 10 weeks. So after 10 weeks, you don't need to give the progesterone supplementation anymore. If you have very high levels, you could...
Why do you even need to give progesterone supplementation?
You're going to have necrosis, release of prostaglandins. And if there is no progesterone, or if the progesterone starts to fall, you're going to have spiral arteriolar spasm, you're going to have necrosis, release of prostaglandins, and you're going to have shedding off of the endometrium. In order to maintain the site of implantation and the normal pregnancy, you need to have continuation of the production of progesterone by the corpus luteum. The beta-HCG is what signals to the corpus luteum you need to continue producing progesterone. Now, many pregnancies where there is concern about a corpus luteum deficit, patients will be put on vaginal progesterone suppositories. How long do you need to continue those progesterone suppositories? Well, the placental would take over between 8 to 10 weeks. So after 10 weeks, you don't need to give the progesterone supplementation anymore. If you have very high...
Okay, when do you have corpus luteum deficit? Corpus luteum deficit. Luteal phase deficit, corpus luteum deficiency, is thought to be an important factor in the pathology. Okay. Supplemental, he just said supplemental progesterone suppositories. So progesterone okay.
Have a twin pregnancy, and we just talked about a hydatidiform mole. If you have levels which are falling, that's not good. You have a pregnancy that is not viable. It could be an ectopic pregnancy, or it could be a spontaneous abortion, which is happening.
That's weird. I thought, okay, he said falling levels of beta-HCG is ectopic. Miscarriage falling? Okay, a miscarriage is falling.
Pregnancy that is not viable, it could be an ectopic pregnancy, or it could be a spontaneous abortion, which is happening. The next hormone we'll talk about is human placental lactogen. It is also known as human chorionic somatomammotrophin. It is actually the fetal growth hormone. It is similar to human growth hormone and prolactin in its sequence of amino acids. In pregnancy, it normally will rise throughout the pregnancy. Now remember, beta-HCG goes up and then it comes down. In this case, HPL continues throughout the pregnancy. So a rising HPL is indication of a healthy pregnancy. Now what does HPL do in terms of maternal medical complications? HPL antagonizes the effect of insulin. So early in the pregnancy, that's going to be a minimal effect. Later on in pregnancy, that can become significant. And in patients who are genetically predisposed, who may have some insulin resistance anyway, with the rising levels of HPL, particularly in the second trimester, you have the onset of gestational diabetes. And after the pregnancy is over, the placenta is removed, the HPL goes away, and the gestational diabetes usually reverses. If you have...
Okay, how do you diagnose gestational diabetes? I think more than 20 weeks. If you have 2 or more, yeah. Timeline. 24 to 28 weeks. Yeah, that's the screening. You should screen 24 to 28 weeks.
HPL. That also is not a good sign, just as falling levels of HCG. Next hormone we'll talk of HPL is over, the placenta is removed, the HPL goes away, and the gestational diabetes usually reverses. If you have falling levels of HPL, that also is not a good sign, just as falling levels of HCG. Next hormone we'll talk about is progesterone. That also is not a... The HPL goes away, and the gestational diabetes usually reverses. If you have falling levels of HPL, that also is not a good sign, just as falling levels of HCG. Next hormone we'll talk about is progesterone. For in support of gesterone, gestation. So intuitively we would say this hormone supports, continues the pregnancy. Very important hormone, progesterone. Where is it produced? Well, it depends. In the non-pregnant state, we already talked about this, progesterone is produced by the corpus luteum. The corpus luteum. Now, if pregnancy occurs and beta-HCG is then released, the beta-HCG maintains the function of the corpus luteum for the first 8 weeks of the pregnancy. If you would take out the corpus luteum, within the first 8 weeks of pregnancy, the pregnancy would be lost because it is dependent upon those levels of progesterone. After 10 weeks, the placenta now produces progesterone in adequate amounts that you don't need to have it. In fact, you could take out the ovaries, you could take out the corpus luteum, and the pregnancy will continue normally. It's between that 8 to 10 weeks where there is both the contribution of the corpus luteum and the placenta.
Okay, wait. So we have less than 10 weeks, and so 10 weeks is the cutoff point where the corpus luteum changes to placenta. Placenta supplies the progesterone now. Okay, and then we could have a problem with the corpus luteum. Then we give vaginal progesterone suppositories.
Progesterone in early pregnancy is to change the endometrial lining so it is favorable for implantation. Without that, you're not going to have implantation. In the latter part of pregnancy, it stabilizes the myometrium. We'll talk about that when we talk about preterm labor prevention, and it can prevent the premature contractions, which can lead to preterm labor. So that is the progesterone.
Okay, secretory endometrium ready for implantation, stabilize myometrium to prevent preterm labor. Yeah, it makes sense because yeah.
Talk about is estrogen. Now, estrogen in a woman's life can vary, which is a predominant form. There is estrone, E1, estradiol, which is E2, and
okay, I remember that. Estriol is like the placental one. Estrone is the one from fat cells. Estradiol is the one from the ovary. Yeah, this is placenta. This is estrone is the fat cells, and estradiol is the ovary. I hope I'm right.
E3. And in case you're interested, this is a structural formula for each of those. I'm sure you're happy to know that. You probably are just as pleased to forget about step 1. But notice the hydroxyl groups. Estrone has 1 hydroxyl group, estradiol has 2, and estriol has 3, and that's why we have the 1, 2, and the 3. The predominant estrogen in a woman's life will vary. In the non-pregnant reproductive years, it is estradiol. Where is it produced? It is produced by the granulosa cells of the follicle.
Okay, I said this is placenta. This is yeah.
The follicle is the source of estradiol. Estriol is the predominant hormone during pregnancy, and it is produced by the placenta. Now, actually, fetal dehydroepiandrosterone sulfate crosses from the fetus, passes through the placenta, and it is converted from DHES into estriol, and at very high levels in the pregnancy. After menopause, estrone is the primary estrogen, and it is produced in the adipose tissue from adrenal steroids. It's interesting to know that estrogens are converted from androgens by the aromatase enzyme, and that is true of the reproductive years, after the reproductive years, or during pregnancy.
Okay.
Okay, welcome to...
Let's see next one. Holy, that's 40 minutes. It doesn't matter. I'm going to finish the entire Kaplan videos. I don't care. Until the QBank fixes, I'm going to do the 40 questions. Okay, it's not working.
All right, changes in specific organs. And
yeah, this is high yield actually. But I know pretty much all of it, so I'm going to just speed it up.
There is probably no organ in a woman's body that isn't affected by pregnancy. So we will look at the normal physiologic changes of pregnancy. Let's first look at skin. Stria gravidarum. The lay term for that is stretch marks. And it's interesting, women who develop significant stretch marks are probably reflecting changes in their collagen. And genetically, a woman who has stretch marks has a probably less stretchable collagen and has a higher rate of lacerations in childbirth. Here's a woman who's got some fairly prominent stria gravidarum. Now, I've seen some women who in the first trimester already have stria gravidarum. Other women who have twins or triplets in the third trimester never develop them. Why not? Well, here's something that I have for sale. It is called Stretch Mark Cream. Actually, I don't have it for sale, but you can buy it on the internet. And it is an unconditional money-back guarantee. What do you think? Nah, I doubt it. Only costs $49.95 for 1 bottle of it. I doubt it. I think it's probably more genetics. If your mother had it, if your sister had them, you're probably going to get them too. Skin changes, looking at increased vascularity. And we're going to look at spider angiomata, palmarerythema, Chadwick sign. Now, why is there increased in vascularity? It is probably because of the smooth muscle relaxing effect of progesterone, which causes the dilation of the vessels. Here you can see spider angiomata. Let's take a closer look. And here they are. And you can see how they kind of have this spidery shape. What is it that causes this? It is the increased estrogen. If you would put your finger on it, it would blanch as the blood is...
Second here. Okay, I know this. These two are in liver failure. Chadwick sign. I don't know what Chadwick sign is. Chadwick sign. Ah, right. The cervix becomes blue, I think. Yeah, I remember that. Yeah. Yeah, that's pregnant because of progesterone relaxing smooth muscle effect, vasodilation.
Clarity. It is probably because of the smooth muscle relaxing effect of progesterone, which causes the dilation of the vessels. Here you can see spider angiomata. Let's take a closer look. And here they are. And you can see how they kind of have this spidery shape. What is it that causes this? It is the increased estrogen. If you would put your finger on it, it would blanch as the blood is forced away. So you take...
Wait, he just said increased progesterone. Yeah. So in liver failure, the liver metabolism is screwed up, so estrogen accumulates.
away your finger, it comes back. Now, men can also get this. Yeah, men can get this. Under what condition? If they have liver failure, and if they have high levels of estrogen, they will get spider angiomata just like this. Palmarerythema, and this woman really shows it well on this picture. Look at the increase in blood flow to the fingers. A pregnant woman will not get cold and clammy hands. If you're looking for cold and clammy hands as a sign of hypotension, don't look for that in the pregnant woman until she's just about ready to go under, because you have this increase in blood flow. This chart shows the increase in blood flow to the leg, the forearm, and the foot, and there's not a great deal of difference. But look at what happens to the hand. The palmarerythema, significant increase in skin blood flow. And why is this? It's to get rid of the heat production from the fetus, which is transferred out through the mother. We also have increased pigmentation in the skin, and this is often seen in the form of linea nigra, and then we have the chloasma, which is also the skin pigmentation on the face. Here we have a patient who's got significant linea nigra. This is often seen in women who have probably darker complexion, less so in women who are blonde. Does it go away after? Maybe a little bit, but not a whole lot. Here we have chloasma, which is this increase in pigmentation on the skin, and that can be on the face and can be significant. You may get some resolution, but frequently, once you got it, you got it.
Okay, 1 second. All right, so in my course, I tried to get the pictures, but I think I have to, like, permission courtesy. Do I have to, like, contact people who have these pictures and tell them, hey, I want to use it in my course? That's insane.
And can be significant. You may get some resolution, but frequently, once you got it, you got it. All right, that was the skin. Let's move on to cardiovascular changes, and we can see changes in the arterial side as well as in the venous side. What happens to systolic arterial blood pressure in pregnancy? It goes down. What happens to diastolic blood flow during pregnancy?
Okay,
it goes.
Why is there pigmentation? I don't remember. Why did they say pigmentation happens?
Why is a bit of the heat production from the fetus, which is transferred out through the mother. We also have increased pigmentation in the skin, and this is often seen in the form of linea nigra, and then we have the chloasma, which is also the skin pigmentation on the face. Here we have a patient who's got significant linea
Oh, I didn't say. Why is there pigmentation in pregnant women? Whatever. Doesn't matter. It's easy to remember anyway.
side. What happens to systolic arterial blood pressure in pregnancy? It goes down. What happens to diastolic blood flow during pregnancy? It goes down even more. So both systolic and diastolic blood pressure go down in pregnancy.
Okay, wait. The reason diastolic goes more is because the progesterone relaxes the peripheral vasculature, which is the main controller of diastolic blood pressure. Yeah.
just coming up next. Venous pressure, central venous pressure does not change. So the CVP,
Makes sense, but doesn't really have any effect on this. Not really as systolic blood pressure, and because the heart is the main controller. Let's see the venous.
go down in pregnancy. I'll show you a slide of that just coming up next. Venous pressure, central venous pressure does not change. So the CVP, if you would take that, should be unchanged in pregnancy. But the femoral venous pressure goes up significantly, 2 to 3-fold. Peripheral vascular resistance also goes down. Now, interestingly, all of these changes are really to enhance the uteroplacental blood flow. And this is a positive thing for maintaining the pregnancy. Here we have a chart showing the change in blood pressure, systolic and diastolic, non-pregnant to 40 weeks, and you see there is a decrease in systolic blood pressure. There is even more of a decrease in diastolic blood pressure. Now you'll see that there will be even at the first trimester, this vertical line that you already have a decrease. It does gradually go up in the latter part of the pregnancy, but if you'll notice, it never is higher during pregnancy than it was prior to pregnancy. It should never go up. Blood pressure never is higher in pregnancy than in the non-pregnant state, normally. This shows femoral venous pressure, and you can see it goes up from about 9 up to 25, almost a 3-fold increase in femoral venous pressure. That's in the lower part of the body. Now, what does that lead to? Varicose veins and hemorrhoids.
That makes sense because plasma volume increases, so it pulls. In addition, the gravid uterus, I think, compresses on the venous return, something like that.
Patient who is 5'11", who has twins in the 3rd trimester. Would you like to have something like this?
No.
This is a patient who is 40 years old and who has just one baby. Significant varicosities. I've seen patients who have varicosities so severe during pregnancy, they can't walk. They have to be in a wheelchair. What happens after the pregnancy is over? It typically goes away. Hemorrhoids, no fun. Jimmy Carter, President of the United States, had hemorrhoids. Well, many pregnant women also have hemorrhoids. And that is almost normal. All right, now we're going to look at further cardiovascular changes. We're going to look at plasma volume. Now, plasma volume goes up. It goes up by 50%. Now, the normal blood volume of a non-pregnant woman is about 5 liters. So we're going to have 7.5 liters of blood volume during the pregnancy. Heart rate goes up. And that's a normal change in pregnancy. Heart rate rises. Stroke volume goes up. Now, if you take heart rate and stroke volume, those two together make cardiac output. Volume goes up, and then obviously cardiac output goes up. What falls is peripheral vascular resistance. And all of this, again, is to enhance the blood flow across the uteroplacental unit. Volume make cardiac output. So heart rate goes up, stroke volume goes up, and then obviously cardiac output goes up. What falls is peripheral vascular resistance. And all of this, again, is to enhance the blood flow across the uteroplacental unit. Plasma volume here you can see goes up significantly, even as early as the 1st trimester. Plasma volume goes up. Now what this slide also shows, which I think is of interest, if a pregnant woman expands her blood volume better, the fetal weight is higher. And we'll talk about this under heart murmurs, which are coming up shortly. If a pregnant woman does not have a systolic diamond-shaped ejection murmur, I'm concerned she hasn't expanded her blood volume, and she may have a small baby. This looks at mean arterial pressure and peripheral vascular resistance, and you can see they both go down. This is what happens to heart rate. This is what happens to stroke volume. And this is what happens to cardiac output. Cardiac output is a function of both stroke volume and heart rate. And you can see that even with the 1st trimester, we have a significant increase in heart rate and a significant increase in stroke volume, which then leads to a 40 to 45% increase in cardiac output, even by the 1st trimester. So a patient who is barely compensating with cardiac disease, by the end of the 1st trimester, you're going to know it if she's going to have a problem. I had a patient once that was referred to me.
Okay. Wait, he said...
Heart rate. This is what happens to stroke volume. And this is what
All right, these are the weeks of gestation. These are the percentage.
happens to cardiac output.
Okay.
Cardiac output is a function of both stroke volume and heart rate. And you can see that even with the 1st trimester, we have a significant increase in heart rate and a significant increase in stroke volume, which then leads to a 40 to 45% increase in cardiac output, even by the 1st trimester. So a patient who is barely compensating with cardiac disease, by the end of the 1st trimester, you're going to know it if she's going to have a problem. I had a patient once that was referred to me for a therapeutic abortion, and she was 20 weeks gestation. Now, she had corrected tetralogy of Fallot. And when I came in the office, she was sitting quietly on the chair, and I said, "How are you doing?" She said, "I'm doing fine." I said, "How many pillows do you use when you sleep at night?" "Just one pillow." I said, "Do you have any activity limitation at all?" "No." I said, "Do you work outside the home?" "Yeah." She says, "I drive a rapid transit bus." Here she is, already at 20 weeks. Is she in trouble? No. She has done well in adapting to the increase in cardiac output and did well throughout the pregnancy. She did not need an abortion at all. Now, when I was in China, some of the traditional methods of making diagnosis include...
Wait a minute, so why is he saying that example to... He just said that if somebody has like a problem in the heart is going to appear after 20 weeks, right?
The 1st trimester, you're going to know it if she's going to have a problem. I had a patient once that was referred to me for him in the office. She was sitting quietly on the chair, and I said, "How are you doing?" She said, "I'm doing fine." Activity limitation at all? No. I said, "Do you work outside the home?" "Yeah." She says, "I drive a rapid transit bus." Here she is, already at 20 weeks. Is she in trouble? No. She has done well in adapting to the increase in cardiac output and did well throughout the pregnancy. She did not need an abortion at all. Now, when I was in China, some of the traditional methods of making diagnosis include palpating the pulse. Now, you also look at the tongue, like this. Now, frankly, I don't know what to look for on the tongue, but they tell me that you've got here the intestines, here is the kidneys and the bladder, here is the spleen and stomach, and the heart is down here. Did you know that? But the pulse is really important. And you notice you palpate in 3 different locations. And there are various things that you will palpate for. There are 9 areas of diagnostic information on each wrist that you will palpate. And once the traditional practitioner has made the diagnosis, they send you then to the herbologist, who will then give you the herbs. You think there's anything to that? Well, let me tell you, I suspect there's a lot more wisdom in traditional cultures than we understand. And I would not poo-poo what they do by any stretch of the imagination. Anyhow, continuing on, cardiac output varies by maternal position. Now, here we have a woman, obviously in the 3rd trimester, who is laying...
I don't really understand why he's mentioning these examples, to be honest. Okay, whatever.
There's a lot more wisdom in traditional cultures than we understand. And I would not poo-poo what they do by any stretch of the imagination. Anyhow, continuing on, cardiac output varies by maternal position. Now, here we have a woman, obviously in the 3rd trimester, who is laying supine, and here she is on her side. One of the concerns about laying on her back is what we call supine hypotensive disorder. The inferior vena cava, which is thin-walled, gets compressed by the large uterus, and you have decreased cardiac return. The heart can only pump out what comes into it, and so you have decreased cardiac output, and the patient gets faint. And I do a lot of obstetrical ultrasounds because my major area of interest is maternal fetal medicine, and patients who have twins, particularly when I'm doing an ultrasound on them, they're laying on their back. After a few minutes, they say, "Doctor, I think I'm going to pass out." Well, what do you do? She's probably got an inferior vena cava compression. What we're going to do is to lay her on her side. We're going to lay her on her left side, and when she lays on her left side, the uterus then rests on the aorta, which is thick-walled, high head of pressure. You're not going to get compression of that, and she'll do well. So the supine hypotensive disorder. It's important when we look at cardiac output to indicate what the mother's position is, because if she's laying on her back, you will get a falsely decreased cardiac output. Cardiac output varies by stage of labor. And here we have a table which looks at the non-pregnant, the late pregnancy. Now, what increases the heart rate with late pregnancy? Well, we talked about this. It is increase in heart rate and increase in stroke volume. In the first stage of labor, the cardiac output goes up. What causes that? The pain of labor increases the heart rate, which increases the cardiac output. How about stage 2? In stage 2, it goes up even more. And here we have the patient who is working. She's pushing. She's trying to get this baby out. That increase in heart rate causes an increase in cardiac output. Now, what is fascinating is the greatest increase in cardiac output is postpartum. Postpartum. What is it that causes that increase in cardiac output so high? This is important when we look at postpartum management because there is the venous sinusoids in the uterus are filled with blood. Once the placenta is out and the uterus contracts, there is an autotransfusion of 600 to 800 cc's of uteroplacental blood, which rapidly comes into the peripheral circulation. Now, if you're giving a blood transfusion...
Okay, one sec here. All right, so over the course of pregnancy, non-pregnant, low. Late pregnant increases a little bit. Stage 1 because she's pushing. Stage 2 and 1 because she's pushing and whatever, doing work. She's increasing postpartum. So
pushing. She's trying to get this baby out. That increase in heart rate causes an increase in cardiac output. Now, what is fascinating is the greatest increase in cardiac output is postpartum. Postpartum. What is it that causes that increase in cardiac output so high? This is important when we look at postpartum management because there is the venous sinusoids in the uterus are filled with blood. Once the placenta is out and the uterus contracts, there is an autotransfusion of 600 to 800 cc's of uteroplacental blood, which rapidly comes into the peripheral circulation. Now, if you're giving a blood transfusion and you write the orders, transfuse the patient with a unit of blood, over what period of time? You typically say we're going to transfuse a unit of blood over 1 to 2 hours. How long does it take for this autotransfusion to take place? Minutes. You have this rapid increase in plasma volume. Plus, you have a loss of the low-resistant shunt, and up goes the cardiac output. So the bottom line is, when in pregnancy is the greatest risk of cardiac failure. It's not in the first or second stage of labor. It is when the placenta comes out.
Wow.
We have many patients who have heart.
Okay, that makes sense. Watch for postpartum heart failure from autotransfusion of uteroplacental blood rapidly into the peripheral circulation. Okay.
Blood, which rapidly comes into the peripheral circulation. Now, if you're giving a blood transfusion and you write the orders, transfuse the patient with a unit of blood, over what period of time? You typically say we're going to transfuse a unit of blood over 1 to 2 hours. How long does it take for this autotransfusion to take place? Minutes. You have this rapid increase in plasma volume. Plus, you have a loss of the low-resistant shunt, and up goes the cardiac output. So the bottom line is, when in pregnancy is the greatest risk of cardiac failure.
Damn.
It's not in the first or second stage of labor. It is when the placenta comes out. We have many patients who have heart disease who some of the consultants will say, well, they should have a cesarean delivery to protect the heart. Can you prevent removal of the placenta with a cesarean? No. So even with cesarean, that risk of cardiac failure is increased because of the autotransfusion of blood. Heart murmurs. What happens to heart murmurs in pregnancy? Are heart murmurs ever normal? And the answer is yes. There is normally a mid-systolic ejection murmur. It should not be grade 6, but it should be present, and you should hear it. Here we've got the systole, and here we have diastole. And you notice that this is a crescendo-decrescendo murmur, which is heard only during systole. It goes up in sound, in volume, and then it comes down. That is during systole. And what this is a reflection of is increase in sound, in volume. That this is a crescendo-decrescendo murmur, which is heard only during systole. It goes up in sound, in volume, and then it comes down. That is during systole. And what this is a reflection of is increase in blood volume and the increase in blood flow across the pulmonary and the aortic valves. And those are normal. But diastolic murmurs, pansystolic murmurs, are never normal during pregnancy. Now let's look at the hematologic changes which occur. And these are significant. Red blood cell mass goes up in pregnancy. It goes up about a third. So let's say 30% increase in red blood cell mass. Plasma volume goes up 50%. So both go up, but the plasma volume goes up more. That results in a decrease in hemoglobin and hematocrit. Now, is that anemia? No. Anemia is decreased in that occur, and these are significant. Red blood cell mass goes up in pregnancy. It goes up about a third, so let's say 30% increase in red blood cell mass. Plasma volume goes up 50%. So both go up, but the plasma volume goes up more. That results in a decrease in hemoglobin and hematocrit. Now, is that anemia? No. Anemia is decrease in oxygen carrying capacity. When you increase...
1 second. Why is the red blood cell mass up? Okay, whatever. Growth factor.
Hematocrit. Now, is that anemia? No. Anemia is decrease in oxygen carrying capacity. When you increase the red blood cell mass, you increase oxygen carrying capacity. So even though the hemoglobin and hematocrit decline, that is normal in pregnancy. And it bugs my soul when laboratories send out their results using non-pregnant reference ranges. Because when you look at the report of a pregnant woman, her hemoglobin may very well be 11, and that's called anemia. And it's not anemia at all.
Okay.
We'll talk more about
11 is normal. 11. Oops.
You type per, and you can see it increase, and the rate will follow and will also go up. Let's we'll talk more about capacity. So even though the hemoglobin and hematocrit decline, that is normal in pregnancy, and it bugs my soul when laboratories send out their results using non-pregnant reference ranges. Because when you look at the report of a pregnant woman, her hemoglobin may very well be 11, and that's called anemia, and it's not anemia at all. We'll talk more about that. White blood cell count goes up. Normal white blood count during, or in a non-pregnant woman, maybe 10,000. In pregnancy, 16,000. Sedimentation rate goes up.
Wow.
Why does
also white blood cell count go up? 16,000. So normally it's 4,000 to 11,000, but in pregnancy it could rise to 16. Okay, why? Blood cells, cell count increases. ايوه لا في حاجة ولا إيه؟ Okay, is it normal? Wait, why is it high? Okay, I'll just memorize it because there is a fetus, there is a foreign body in the mother, so the white blood cell count increases. I'm just gonna use that. Okay, so white blood cell count is higher. Sedimentation rate, how about it?
Maybe 10,000. In pregnancy, 16,000. Sedimentation rate goes up. Why does sedimentation rate go up? Because your gamma globulins go up. And frankly, all of your plasma proteins go up with the exception of albumin. And so when your gamma globulins, your beta globulins go up, sedimentation rate will follow and will also go up. Let's say you're a surgeon, and a pregnant woman comes in the first trimester, and she has right lower quadrant pain. One of your concerns is going to be appendicitis, right? So what are you going to order? You're going to order a white count or a CBC, and you're going to look at a sed rate. Well, the fact is that normally those are going to be increased in pregnancy. So you really can hardly use a white count and a sed rate for evidence of infection in pregnancy because they normally go up. Factors 7, 8, 9, and 10 go up. Now, what is the impact of that? When you increase clotting factors, the risk of thrombosis goes up. Now, there are lots of other reasons why thrombosis goes up, but one of those is because of the increase in the clotting factors. So pregnancy is a hypercoagulable state. Platelet count really stays within the same range in a non-pregnant woman. So it's important in pregnancy that we adjust mentally our reference ranges when we look at white blood count, we look at sedimentation rate, when we look at the factors 7, 8, 9, and 10, and we look at hemoglobin hematocrit, because they are not the same. Okay, this next slide we've already seen when we looked at increase in plasma volume, but you can see that there is an increase in plasma volume which occurs even as early as the first trimester. So here we have an increase in plasma volume, increase in blood volume, and red blood cell mass. And you can see that red blood cell mass does go up, even though the hemoglobin and hematocrit will drop. And here is your hemoglobin. Notice in the non-pregnant state, normal reference range is from 12.5 to 14.5. Here we have the first trimester, and you notice how it is already dropped by the first trimester. And where is the lowest point in the pregnancy of the hemoglobin? And you can see it is around 25 to 30 weeks. That's why one of the laboratory tests that we order in the latter part of pregnancy is a cell profile to look for hemoglobin and hematocrit. Because if she's not anemic, by 30 weeks, she probably will not be anemic. Again, to reiterate, physiologic anemia is not a true anemia because we have an increase in oxygen carrying capacity as a result of the increase in red blood cell mass, but because of the hemodilution, we have a physiologic anemia. All right, now we move to the gastrointestinal tract, and there's a lot of changes here that are very troublesome for women who are pregnant. Firstly, smooth muscle wall tone goes down, resulting in decreased motility. Now, what's the mechanism of that? It's probably because of the smooth muscle relaxing effect of progesterone. And progesterone levels are very high because of placental production. So smooth muscle wall tone goes down, motility goes down. Therefore, the emptying time of the stomach, the emptying time of the gallbladder, of the large and the small bowel will also go up, and the residual volume will go up. If you increase the residual volume of the stomach, at the same time you decrease the gastroesophageal sphincter, what are you looking at? Reflux esophagitis. The most common cause of epigastric pain in pregnancy is reflux esophagitis.
Antibiotic. Shit, I have to take it. Okay, I'll finish that video.
It's so common, so common. Cholelithiasis because of decreased contractility of the gallbladder, and constipation is a major issue for pregnant women. And if they're constipated before they got pregnant, it's going to be even worse. So what do we want to do? We want to have stool softeners, encourage oral hydration, regular bowel movements. But this is very, very common. Let's look at changes with the lung. If you look at the volume of air that you are moving in and out of your lungs at rest, we call that the tidal volume. Hydration, major issue for pregnant women. So common. What are you looking at? Reflux esophagitis. The most common cause of epigastric pain in pregnancy is reflux esophagitis. It's so common, so common. Cholelithiasis because of decreased contractility of the gallbladder, and constipation is a major issue for pregnant women. And if they were constipated before they got pregnant, it's going to be even worse. So what do we want to do? We want to have stool softeners, encourage oral hydration, regular bowel movements. But this is very, very common. Let's look at changes with the lung. If you look at the volume of air that you are moving in and out of your lungs at rest, we call that the tidal volume. Now, if you take as deep a breath in as you can, the increase in the lung volume is called the inspiratory reserve volume. We put those two together and we call that inspiratory capacity. Then you breathe out as much air as you can. That is called the expiratory reserve volume. And when we put those three together, we have vital capacity. Now, there's still air which is trapped in the lung. Those take as
Wait
deep.
a minute.
All right, changes in inhalation. Minute ventilation of relaxed abdomen. So come. Air as deep a breath in as you can. Move on. Let's look at changes with the lung. If you look at the volume of air that you are moving in and out of your lungs at rest, we call that the tidal volume. Now, if you take...
What does the word tidal mean? Rising and falling, flowing. Okay, that makes sense. Tidal, tides.
A breath in as you can, the increase in the lung volume is called the inspiratory reserve volume. We put those two together and we call that inspiratory capacity. Then you breathe out as much air as you can.
Yeah.
That is called the expiratory reserve volume. And together we have vital capacity. Now there's still air which is trapped in the lung, and we call that residual volume. We put all four of these together and we have total lung capacity. Now what happens in pregnancy? This is a non-pregnant woman, this is a pregnant woman, and as you can see, tidal volume goes up. All of the others go down. Inspiratory reserve volume, expiratory reserve volume, residual volume, all will go down. So the
She's using everything.
main change in the lungs is the tidal volume. The tidal volume goes up. That's the air moved at rest. This is a graph which shows the normal changes in tidal volume, and you can see that they go up. Now, what is the impact of that? Well, let's look at minute ventilation. Minute ventilation is a volume of air moved by the lungs in 1 minute, and it is a product of respiratory rate and tidal volume. You know, a parallel to this would be cardiac output. Cardiac output is a product of not respiratory rate, but heart rate, not tidal volume, but stroke volume. And that's how we get cardiac output. The minute ventilation is an expression of the volume of air moved by the lungs in 1 minute.
Okay, minute ventilation. That is physiology. Minute
Ventilation. Respiratory rate times tidal volume.
Happens to respiratory rate. Now we know the heart rate goes up. Does respiratory rate go up? No. There's no change in respiratory rate. And here you can see this graphically portrayed. Respiratory rate stays about the same. But what happens to tidal volume? Well, we've also said the tidal volume goes up. So if respiratory rate is unchanged, stays equal, tidal volume goes up, minute ventilation will go up. So tidal volume goes up, but all of the other volumes go down. Now that's pretty easy to remember. Tidal volume is the main one which changes. Now there are other changes to the lungs. We get a widened thoracic diameter because of the uterus pressing up, and we have a doming of the diaphragm because of the pushing up.
Widened thoracic diameter. Okay.
Of the pregnant uterus. At a widened thoracic diameter because of the uterus pressing up, and we have a doming of the diaphragm because of the pushing up of the pregnant uterus. Now, if we look at the increase in minute ventilation on blood gases, it is significant. What happens to PCO2 if minute ventilation goes up? PCO2 goes down because you have a respiratory alkalosis. What happens to pH goes up. Now, if we look at the increase in minute ventilation on blood gases, it is significant. What happens to PCO2 if minute ventilation goes up? PCO2 goes down because you have a respiratory alkalosis. What happens to pH if PCO2 goes down? pH goes up. So we have an increase in minute ventilation, we have a decrease in PCO2, we have a rise in the pH. That is a normal change. If you would get blood gases on a pregnant woman, her PCO2 instead of being 40 is going to be 35. Her pH instead of being 7.4 is going to be 7.45. And that is a normal physiologic change. And when you get blood gases on a pregnant woman, you better mentally take that into account. Otherwise, you may think that there is a problem. Now, if pH goes up, what happens to urine pH? Urine pH goes up too, because when you have the respiratory alkalosis, the increase in bicarb is adapted by putting the bicarbonate into the urine, and the urine, instead of being acidic, now becomes alkaline.
I dozed off. Sorry.
Physiologic 5. Her pH, instead of being 7.4, is going to be 7.45. And that is a normal physiologic change. And when you get blood gases on a pregnant woman, you better mentally take that into account. Otherwise, you may think that there is a problem. Now, if pH goes up, what happens to urine pH? Urine pH goes up too, because when you have the respiratory alkalosis, the increase in bicarb is adapted by putting the bicarbonate into the urine, and the urine, instead of being acidic, now becomes alkaline. And that's one reason why there is an increase in urinary tract infections in pregnancy, because the pH goes up. And that predisposes. There are other reasons as well, but this is one of those for increase in urinary tract infections. So here we have PO2 goes up, PCO2 goes down, bicarb goes down. Normal changes of pregnancy. Let's look at the kidneys now. And that alkalosis, the increase in bicarb, is adapted by putting the bicarbonate into the urine, and the urine, instead of being acidic, now becomes alkaline. And that's one reason why there is an increase in urinary tract infections in pregnancy, because and the pH into account. Otherwise, you may think that there is a problem. Now, if pH goes up, what happens to urine pH? Urine pH goes up too, because when you have the respiratory alkalosis, the increase in bicarb is adapted by putting the bicarbonate into the urine, and the urine, instead of being acidic, now becomes alkaline. And that's one reason why there is an increase in urinary tract infections in pregnancy, because the pH goes up. And that predisposes. There are other reasons as well, but this is one of those for increase in urinary tract infections. So here we have PO2 goes up, PCO2 goes down, bicarb goes down. Normal changes of pregnancy. Let's look at the kidneys now. In terms of renal anatomy, the kidney size goes up, both the length and width of the kidney. The renal pelvis volume goes up. That is the urine, which is in the renal pelvis. And the ureters increase in size. A normal ureter should be about the size of a pencil. In pregnancy, it will be about the size of your thumb. Now, when you take urine, well, actually, if you take any fluid, and bicarb goes down. Normal changes of pregnancy. Let's look at the kidneys now. In terms of renal anatomy, the kidney size goes up, both the length and width of the kidney. The renal pelvis volume goes up. That is the urine, which is in the renal pelvis. And the ureters increase in size. A normal ureter should be about the size of a pencil. In pregnancy, it will be about the size of your thumb. Now, when you take urine, well, actually, if you take any fluid and put it through a larger diameter tube, what happens to the flow velocity? Decreases. So you really have stasis of urine. So you put those two together, increase in the pH, a stasis of the urine, and you're going to increase the risk of UTIs. So here we have the kidney. The kidney length increases, the kidney width increases. And this is probably because of the increased renal blood flow, because of the increased cardiac output. So you have a compensatory hypertrophy. Now what happens after the pregnancy is over? Cardiac output goes back down, and it probably takes 6 to 8 weeks in order for the kidneys to go back to their normal size. Here we have an image of the urinary system, and you can see the kidneys, and the ureters and the bladder. The ureter increases in size, and which side does that occur more likely? It is 90% on the right side than the left side. Now, which side do you think pyelonephritis occurs more commonly in pregnancy? 90% on the right side.
Wait, right.
As well. Now, why is that? I don't have any good explanation. Some people say that as the pregnant uterus rests on the pelvic brim, it compresses the ureter and you have reflux. Yeah, but this can happen, the dilation of the ureter, even in the first trimester. So just remember that. This is an ultrasound of a kidney in pregnancy, and you can see the increase in the renal pelvis. So renal anatomy changes. How about renal function? That also changes. Renal plasma flow goes up, glomerular filtration rate goes up, and creatinine clearance goes up. So basically we have increase in cardiac output, increase in renal blood flow, which then increases the clearance of waste products. So GFR, creatinine clearance. What is a normal creatinine clearance in a non-pregnant woman? Maybe 100 to 120. In pregnancy, what do you see? 150 to 180, and that's normal. Because we have this increase in the clearance of metabolic waste then, our BUN will go down, serum creatinine will go down, and uric acid will go down. Now, normal BUN in a non-pregnant woman is maybe 10 to 15, even up to 20. In pregnancy, it should be less than 10. Creatinine in a non-pregnant woman, 1, 1.2. In pregnancy, 0.5, 0.6. Uric acid.
Okay, plasma flow goes up, GFR goes up, creatinine clearance goes up, BUN goes down, makes sense. Creatinine goes down. So, okay.
7 to 8. In pregnancy, it should be 4 or 5. So these need to be taken into consideration when you look at the normal laboratory values of a pregnant woman. Glucose in the urine, we call that glucosuria. What happens to that in pregnancy? Normally, it goes up. There is an increase in spillage of glucose into urine. We call this splay. And when you check the urine, does that mean, if it's positive, that the pregnant woman has diabetes? No. How do we make a diagnosis of diabetes? We measure the blood glucose, not the urine glucose. This is so common. Frankly, I think testing of urinary glucose on prenatal visits is worthless because we don't make a diagnosis of diabetes based upon urine anyway. Now, protein in the urine is a different story. What happens to urine protein in pregnancy? And it does not change. So while glucosuria is common and to be expected, proteinuria is not. Okay, so that's the kidneys, the renal function. Now let's look at...
Wow, proteinuria is not. I saw a question that had a woman that's pregnant, she had trace proteinuria, and I thought that's fine. Q-Bank's still not working.
We'll start out with the pituitary. There is an increase in blood flow to the pituitary, the same as there's an increase in blood flow to the kidneys. What happens to the size of the pituitary gland in pregnancy? It gets bigger. Increase in blood flow to the pituitary. Now, what does that then result in the risks for? If you have jeopardy of the blood supply of the pituitary, let's say you have postpartum hemorrhage, or you have even an antepartum hemorrhage from placenta previa, or abruptio placenta, what are you looking at risk of? Sheehan syndrome. Sheehan syndrome, infarction of the pituitary because of hypotension. And what hormones will be involved? All of your trophic hormones. The most susceptible hormone is going to be prolactin and failure of lactation, which could occur. The next hormones that go is your gonadotropins, your LH and your FSH. And the last ones would be ACTH and TSH. But that's Sheehan syndrome. And there is an increased risk of that because of the increase in blood flow. Adrenal glands. The adrenal gland size does not change. But the production of cortisol in pregnancy goes up significantly.
Okay, 1 second. He said the most important one is prolactin, and then FSH, LH, right?
The ACTH and TSH. But that occur. The next hormones that go is your gonadotropins, your LH and your FSH. And the last ones would be ACTH and TSH. But that's Sheehan syndrome. And there is an increased risk of that because of the increase in blood flow. Adrenal glands. The adrenal gland size does not change. But the production of cortisol in pregnancy goes up significantly. Here you can see the rise in cortisol. So we have an increase in HPL, we have an increase in estrogens, we have an increase in progesterone, we have an increase in cortisol. All of those will predispose to gestational diabetes. Thyroid gland. Let's look at thyroid physiology. Thyroid gland size goes up. Is that surprising? The pituitary gland increases in size. Many of the vascular organs go up. So the thyroid gland size goes up. Total T3 and total T4 go up. Why do the total T3 and total T4 go up? Because thyroid...
It's saying OBS disconnected.
gland. Let's look at thyroid physiology. Thyroid gland size goes up. Is that surprising? The pituitary gland increases in size. Many of the vascular organs go up. So the thyroid gland size goes up. Total T3 and total T4 go up. Why do the increase in progesterone? We have an increase in cortisol. All of those will predispose to gestational diabetes. Thyroid gland. Let's look at thyroid physiology. Thyroid gland size goes up. Is that surprising? The pituitary gland increases in size. Many of the vascular organs go up. So the thyroid gland size goes up. Total T3 and total T4 go up. Why do the total T3 and total T4 go up? Because thyroid binding globulin goes up. All of your carrier proteins, all of your carrier globulins, whether it's iron binding globulin, whether it's sex hormone binding globulin, whether it's thyroid binding globulin, they all go up in pregnancy. What's the only protein that doesn't go up? Albumin. Albumin goes down. Now, the normal reference ranges for TSH and TRH, thyroid stimulating hormone and thyroid releasing hormone, there is no fundamental change. The free T3 and free T4, the unbound, do not change. And free thyroxine index does not change. So the parameters that we use for diagnosis of hypothyroidism and hyperthyroidism are basically unchanged. So we can use the same reference ranges for TSH, for T3, T4, and for thyroid.
Okay, that's good to know because I just got a question about hypothyroidism, and the TSH was high, so I said she has hypothyroidism. Okay, I was right. So you don't use like different parameters or whatever. It's just the thyroid gland size increases, total T3, T4 goes up, thyroid binding globulin goes up.
Thyroxine index. Fetal circulation. We need to just look briefly at this because there are some very significant shunts which occur, and there are mainly three. There's the ductus venosus, the foramen ovale, and the ductus arteriosus. Now the ductus venosus takes blood from the umbilical vein and dumps it into the inferior vena cava. The blood from the inferior vena cava will then go into the right atrium. And now we have the second shunt. Blood is shunted from the right atrium into the left atrium. This is an opening in the interatrial septum. The blood goes from the pulmonary artery normally into the lungs, but in the lungs there is no point in the blood going through because there's no oxygenation that occurs in the lungs during pregnancy. And so we have the shunt that takes blood from the pulmonary artery to the descending aorta, and we call that the ductus arteriosus. Now there are medications that the mother can take which can cause constriction of the patent ductus arteriosus in utero, and that is indomethacin. We'll talk about that when we are talking about preterm labor, tocolysis. Okay, so here we have an illustration, and we'll talk about this during pregnancy. And right atrium, vein, fetal circulation. We need to just look briefly at this because there are some very significant shunts which occur, and there are mainly three. There's the ductus venosus, the foramen ovale, and the ductus arteriosus. Now the ductus venosus takes blood from the umbilical vein and dumps it into the inferior vena cava. The blood from the inferior vena cava will then go into the right atrium. And now we have the second shunt. Blood is shunted from the right atrium into the left atrium. This is an opening in the interatrial septum. The blood goes from the pulmonary artery normally into the lungs, but in the lungs there is no point in the blood going through because there's no oxygenation that occurs in the lungs during pregnancy. And so we have the shunt that takes blood from the pulmonary artery to the descending aorta, and we call that the ductus arteriosus. Now there are medications that the mother can take which can cause constriction of the patent ductus arteriosus in utero, and that is indomethacin. We'll talk about that when we are talking about preterm labor, tocolysis. Okay, so here we have an illustration of the fetal circulation. Here is the placenta. Here is the umbilical cord. There are two umbilical arteries which carry blood from the fetus down to the placenta, and there is one umbilical vein that carries blood from the placenta to the fetus. If you want to assess the metabolic status of the fetus, you want to get blood gases, which would be the best reflector of the fetal status, the umbilical arteries or the umbilical vein? And it's going to of the fetus. You want to get blood gases. Which would be the best reflector of the fetal status, the umbilical arteries or the umbilical vein?
Umbilical vein.
And it's going to be the umbilical arteries.
What?
Because to the descending aorta, we call that the ductus arteriosus. Now there are medications that the mother can take which can cause constriction of the patent ductus arteriosus in utero, and that is indomethacin. We'll talk about that when we are talking about preterm labor, tocolysis. Okay, so here we have an illustration of the fetal circulation. Here is the placenta. Here is the umbilical cord. There are two umbilical arteries which carry blood from the fetus down to the placenta, and there is one umbilical vein that carries blood from the placenta to the fetus. If you want to assess the metabolic status of the fetus, you want to get blood gases, which would be the
metabolic. I thought you said like oxygenation.
best reflector of the fetal status, the umbilical arteries or the umbilical vein? and it's going to be the umbilical arteries, because there is deoxygenated blood in the arteries, there is oxygenated blood in the vein. There was a question on the exam once where they asked on the step 2 exam, where in the fetal circulation is the highest PO2? And the highest PO2 is in the umbilical vein just prior to entering into the inferior vena cava. So here again, we've got the 3 shunts. We have the ductus venosus that takes blood from the umbilical vein and puts it into the inferior vena cava. We have the foramen ovale that takes blood from the right atrium and puts it into the left atrium. And so it bypasses the lungs. Blood that does go through from the right atrium into the right ventricle and gets into the pulmonary artery is shunted away from the lungs by going through the ductus arteriosus. There is a difference in the oxygen binding of the fetal hemoglobin and the maternal hemoglobin. And this chart really demonstrates that beautifully. You can see this is the oxygen content of the mother's hemoglobin. This is the oxygen content of the fetal hemoglobin at a given PO2. Now, when I was in medical school, I was taught the fetus lives on the top of Mount Everest. And I've never forgot that, because what it tells me is that the fetus gets by with low PO2 levels without much difficulty. And why is that the case? Well, let's look here. You can see at a PO2 of 30, the mother's oxygen content is less than half of that of the fetus. And the fetus can get by very well with low levels of PO2. And this is because of the oxygen-hemoglobin dissociation curve of hemoglobin F versus hemoglobin A. And that brings us to the end of physiologic changes in pregnancy.
Okay, perfect. That's second video. Let's go. Third video. Okay, I'm not gonna leave the desk until I finish chapter 1. I'm just gonna solve some questions. I hope the QBank is working now. Oh, it's working. Wait, it's saying YouTube is not responding. Okay, what? Yeah, it is. Alright, never mind. Connection poor. Alright. I just solved this one. Which of the following is the most appropriate pharmacotherapy? Okay, motor flagellator organism with jerky movements. Alright, that is easy. That is, what is it? Trichomoniasis. Okay, easy goal. Which of the following is the most appropriate next step in management? Physical examination shows a firm 2 centimeter non-tunnel mass in the right breast. Fine needle aspiration do not show any malignant cells. Mammogram is read non-diagnostic, cannot rule out malignancy. Okay, so now we ruled out malignancy, which is okay. Just a mass that's present for 6 months. She's not concerned, but she believes it can be it was caused by trauma when she was hit in the breast. Okay, that is what's it called? Fat necrosis, I guess. So fine needle aspiration do not show any malignant cells. Should we do like a biopsy? If fine needle aspiration didn't show any malignant cells, should we do a biopsy? I mean, the other answer choices suck. Maybe this one. No, that's not good. Yeah, I guess we're just gonna do a biopsy. Alright. Yeah. Okay, even if it showed, like the fine needle aspiration shows negative finding, you still gotta do a biopsy. Fine needle aspiration results are available only when positive malignancy. Negative FNA does not rule cancer.
In addition, although trauma can lead to breast hematoma, long-lasting masses should be further explored. In such instances, it's important to move to more aggressive means of obtaining better tissue sampling. So the best next step is a radiologically guided core biopsy. All right, that makes sense. Which of the following is the most appropriate next step in management? A symphysis pupus height 25, she's 26. Okay, that's fine. Now it's just no glucose trace protein. See, that's the question I told you about. There is trace protein. Your analysis dipstick shows no glucose and trace protein. All right. Routine prenatal visit. Normal movement. No abdominal pain, no vaginal bleeding, no leakage fluids. Patient routine prenatal laboratory testing and ultrasounds has been normal. Her blood type is O, Rh positive. Her first pregnancy ended with spontaneous vaginal delivery of a male infant at 39 weeks who developed jaundice due to hemolysis and was treated with antibiotics for group B sepsis. Mm-hmm. Oh, wait. She's Rh positive, so there's no need. Repeat STD screening. Did she have an STD? No. "36 weeks. Okay, fuck that shit. Rectovaginal.
All right. Shit, my second screen. Wait. Okay, it's working now. All right, that's fine. Which of the following is the most appropriate next step in management? It shows 3+ protein. Bedside ultrasound shows 32-week pre-presentation fetus with no fetal cardiac activity. I mean, low transverse is fine. Low transverse, she can do oral oxytocin. Wow. Misoprostol is contraindicated in patients who had prior C-section. Damn. So why is C like fine then? C. Alright. However, this patient has another complicating factor. She has had a prior cesarean. As such, misoprostol is contraindicated due to high risk. Okay. Therefore, the delivery plan associated with lowest maternal risk for this patient is a vaginal breech delivery after induction with IV oxytocin. Yeah, I mean he's dead anyway. Like the baby is dead. You can just deliver him. All right. Okay, so this is wrong. All right. Which of the following is the most appropriate next step in management? All right. 26-year-old woman comes to physician for advice regarding hormonal contraceptives. Sexually active with 2 partners is inconsistent with using very contraceptives. She has regular 28-day cycles with some cramps and discomfort at the time of her menses that are relieved by warm bottle compresses. Her last menstrual period is okay, I'm gonna remove the normal stuff, alright? So I'm gonna remove the normal stuff, so that's fine. That's fine. Yeah. I mean that's not fine, to be honest. That's abnormal.
you should use contraception. Discomfort during sexual activity. Alright. Regular, okay, that's fine. That's fine. Last menstrual period was 3 weeks ago. Yeah, so the only problem we have here is that the right vulva appears visibly swollen, and there is a mass in the right vagina near the posterior introitus. No bleeding, no discharge. And then it's the way it looks like, it's cystic, non-tender, mobile, and approximately 2 centimeter in diameter. Marsupialization, I don't know what that is. Warm compresses and SIDS bath. That's not hemorrhoids. This is treatment for hemorrhoids. That's not hemorrhoids. Valvectomy with bilateral lymphadenopathy. I mean, I don't think it's cancer. It's cystic. And it's mobile. No. Oral trimethoprim. I mean, I think we gotta drain it first. Maybe it's an abscess or something. Intravenous vancomycin. Piperacillin tazobactam. No, that's so severe. Oral trimethoprim. Okay, let's go with A. Okay, I suck. Bartholin gland carcinoma is a rare. Okay, yeah, I was right about this. B is severe vulvar abscesses. Fever, yeah, and stuff. Yeah, that's okay. C is recurrent Bartholin cyst. Why is A wrong? But any Bartholin gland mass, including a cyst, is managed with incision and drainage. Okay. To empty the contents of the cyst, followed by placement of a. Alright. Marsupialization is preferred when there have been more than 2 recurrences. What is marsupialization? Oh, okay. Cutting a slit into an abscess and cyst and suturing the edges of the slit to form a continuous surface from the exterior surface to the interior. Okay. Yeah, that makes if it's recurrent, that makes sense. All right. Like, you just keep the abscess open in order not to fill again. So that's why A is wrong. But yeah, you can use incision and drainage too. Followed by placement of a word catheter. What is a word catheter? Cotton bud. Oh, okay. Yeah. Continued drainage of. Alright, so if it is more than 3 centimeter, imagine, like, I have to know that for step 2. If it's more than 3 centimeters, but the problem here is it's less than 3 centimeters, 2 centimeter. So if it's less than or equal to 3, you have to, incision and drainage. And then you can put a word catheter or a marsupialization. Yeah, word catheter if it's just one time. If it's recurrent, you're gonna put word catheter. Wow, I have to know that. Okay, so that's because it's more than or equal to 3 centimeter. Okay. Warm compresses and SIDS baths. Warm compresses and SIDS baths. Alright, so this is the treatment, I guess. Small cysts with warm compresses and sitz baths. Alright, the ducts become obstructed and the duct secretion accumulates behind and the cyst behind the obstruction. Bartholine gland cysts are frequently asymptomatic. However, a larger cyst can present with discomfort, dyspareunia, and difficult sitting. Untreated Bartholine gland cysts frequently resolve, but also can become infected and progress into Bartholine gland abscess, small cysts. Alright, so the treatment for Bartholine cysts, here it is. Okay. Conservatively, with sitz baths, warm compresses, which result in, in their drainage, right? So warm compresses and sitz baths is just the treatment for less than 3 centimeters Bartholine cysts. If it's 3 centimeters or more, you're gonna incise and drain, and you put a word catheter just to continue drainage, or you can use marsupialization if it's recurrent. Okay. Next question. Which of the following is the most likely to diagnosis? So, thick, clumpy discharge, erythema of the vagina. Testing of the vaginal discharge, a pH. Okay, that's Canada. Vaginal itching. She took amoxicillin, which is a risk factor for Canada. I mean, antibiotics, I guess. You kill the normal flora, and then the Candida has a place to grow. Sexually active. All right, let's go with this. Okay, that's easy. Which of the following is the most appropriate next step in management? All right, which of the following is the most appropriate next step in management? Did I solve 40 questions today, or did I solve 20? I solved 40, right? I solved a block, and then now it's just 50. Okay, which of the following is the most appropriate next step in management? Which of the following is the most appropriate next step in management? Digital cervical examination shows the cervix to be 5 centimeter dilated and 90% affected, with the fetal head at -2 station. Okay, I'm gonna finish till question 10 and go. Which of the following is the most appropriate next step in management? So, digital cervical examination shows the cervix to be 5 centimeter dilated, 90% effaced, with the fetal head is -2. She's 34 weeks gestation. Wow, okay. Are we gonna make her give birth right now? Patient was hospitalized 28 for threatened preterm labor when a course of betamethasone was administered. Are we gonna give betamethasone? What is that? Isn't that a corticosteroid? So why do we give it here? I mean, magnesium sulfate, we give it I think 32 weeks. I don't know. Maybe nifedipine is gonna work. Okay, some Kaplan questions are just stupid. Okay, I send them a feedback, like here. Look. Where is it? I sent them a feedback, and they told me they're gonna change the question. But yeah, this is not a stupid question. I'm just stupid.
We don't give nifedipine to stop the labor though. That's dumb. We don't give nifedipine to. Wait, we actually give it to choletic.
بس تعالى نشوف باتريك بتاعه مثلا يعملوا زي فود بانكس مثلا ويوزعوا الناس بعد كده. هو في مور دي كانت مدرسة بتاعتنا عشان لسه اجتماعية عشان هتستخدموا لي حلال باتري أو فود بانك حلال فود بانك بتعمل في بفر يعني شوف مين في مور دي وده ممكن يقلل شوية على العملية وحوش شوية اللي هو أنا معايا يعني أزيد شوية في
I don't understand. That's a weird question. I mean, we're not gonna do anything about this preterm labor. She's 34 weeks. I thought we're just gonna stop the preterm labor.
انت تقريبا فول تايم بتوصلنا فاحنا عايزين نجيب حاجة حلوة تكون مريحاك كده وتحسوها وتكون ما تقعدش تتقابل دي كل شوية يعني لو بريوس مثلا تعمل مثلا بالليل
Oh my god, bro.
ممكن توفر معاك نص اللي انت بتدفعه مثلا بس يعني مش عارف يعني شوف كده لو اسد تحط نوع من تحوشه ان شاء الله وانا هحوش برضو في الصيف ان شاء الله ونجيب حاجه كويسه كده لان هقول لك بقى لان احنا لما يجي والله بنفكر فيه لما نيجي يبقى عندي ان شاء الله في سكول هيبقى عندي مثلا ايه في كويزات بتبدا هي 745 هي بتبداوا كده والله في كويزات وامتحانات 745 فطبعا مش هعرف اتوصل العيال ولا اي حاجه فلازم
I just hope Kaplan's gonna talk about these stuff.
يكون معانا عربيه لان يعني حملي يقل شويه عشان مثلا توصلني بعد كده هو
Hopefully he's gonna talk about this stuff.
بيدنا حاول
Okay, I'm not gonna waste time on this. Which of the following is the best next step in management? Oh, the patient's serum is negative for antiphospholipid syndrome. Antibodies and anti-D antibodies. Okay. It's B negative. Okay, I'm gonna be honest. This is an example of bad elimination. I had no reason I eliminated this. I did have a reason to eliminate this because she is it happened 14 weeks and 16 weeks. I would give progesterone suppository supplementation if she's like 9 weeks. Let me check if I'm right. Yeah, so corpus luteum deficiency could be like a cause. Following mild symptoms. Although this patient's diagnosis is established by her history of recurrent second trimester pregnancy loss, can be established by. So the normal is less than is. I thought that's good. So that's short. That's actually short. Less than 25. Okay, that's nice. I didn't know that. So less than or equal to 25. Or transvaginal ultrasound before 24 weeks. And it's one extremely premature birth. Okay, let's see normal cervical length. Yeah, in pregnancy. Let's see. Okay, 19 weeks gestation. It's supposed to be 37. Wow. Okay, so gestational weeks. Okay, at 18 weeks. Okay, never mind. That's let's see another one. Patient. Oh, this is statistics. Come on, bro. Where's the... Oh, 4 centimeters. So that's 40 millimeters. Okay. Cervical insufficiency is most commonly the result of an intrinsic structural weakness of the cervix. However, it may also occur when subclinical uterine infection or concealed placental bleeding causes an inflammatory response that triggers premature cervical shortening, leading to a pre-viable delivery. Right, so she had a uterine length 10-25 on transfer before 24 weeks gestation. She is 14 and 16. Intrinsic structural weakness, however, it may also occur when subclinical uterine infection or concealed placental bleeding cause an inflammatory response. Okay. So uterine infection or concealed placental bleeding. So, for example, abruption of the placental abruption. That will lead to cervical shortening, leading to pre-viable delivery. All right. Patients diagnosed with cervical insufficiency based on obstetric history typically undergo transvaginal cerclage at 12 to 14 weeks gestation, during which a suture or synthetic tape is used to structurally reinforce the cervix, decreasing the likelihood of subsequent second trimester pregnancy loss. Okay, so when we have second trimester pregnancy loss, it's like 2 after each other, so like 14 weeks, 16 weeks, we should suspect cervical insufficiency. All right. Or a physical examination shows a cervical dilation at 14 to 27 weeks, which is second trimester in asymptomatic patients. So either a shortened cervix, or cervical dilation in second trimester. Okay, and we're talking about less than 25 here. Here it's 20. Okay, let's read this. The presence of cervical insufficiency is referred to in individuals who suffer from repeated second trimester losses by painless cervical dilation due to inability of the uterine cervix to retain pregnancy. The main cause of CI is hypothesized to be due to structural cervical weakness. Could be cervical trauma, risk factor. Congenital cervical abnormalities, presence of short cervical length. Individuals with CI may be either asymptomatic or present with pelvic pressure, which is what she said here. She had pelvic pressure. I mean, makes sense. I think because the fetus is falling. Like, it's not stable. The fetus is not stable, so you're gonna backache. Okay. Change in vaginal discharge consistency and color. Braxton Hicks-like contractions. Physical examination: cervix soft, closed if phase dilated. On Valsalva nova or suprapubic may sometimes show fetal membranes. Okay, let's just move on. Which of the following is the best study to evaluate this patient? What is that? A 24-year-old athlete comes to the physician because of an on and off pain and soreness in their genitals for the past 4 months. Patient reports that the pain is episodic and is triggered while cycling or sitting for long periods of time. They note feeling anxious due to difficulty in performing day-to-day activities and limited sexual activity due to pain. The patient reports having multiple yeast infections in the past. Alright, that's probably a chronic infection. They have one sexual partner, use IUDs for contraception. Oh, this is an IUD, alright. This is the IUD. Their BMI is 23, their temperature 36, whatever.
which of the following is the best study to evaluate this patient? I mean, it looks white. Is that a white discharge? Culture, vaginal pH, maturation index, pressure point testing, gram stain of vaginal discharge. On and off pain and soreness in the genitals for the past 4 months. On and off pain and soreness in the genitals for the past 4 months. Patient reports that the pain is episodic and is triggered while cycling or sitting for long periods. Cycling or sitting. Oh, it's probably I don't know, pelvic inflammatory disease. He's an athlete, so that's definitely a risk factor for something. Episodic. Multiple yeast infection, another risk factor. Don't really know. Culture. There's no fever. Maybe a culture. Addition of potassium hydroxide to vaginal discharge. That's for Canada. No, that's not Canada. Is Canada gonna cause that? I mean, it's just pruritus. Maybe if it's like multiple candidiasis, it might cause like some other symptoms. Let's not eliminate that. Or because multiple yeast infection, so it makes it susceptible for another bacterial infection to come on. Pressure point testing. Gram stain of vaginal discharge. Determine vaginal pH. Kill it. I have no clue. That's whatever. Vulvodynia. No way. This is like white cervix here. If they didn't put this picture, I would have thought of vulvodynia. But this picture, like, gram stain of vaginal discharge is one of the standard methods to diagnose the etiology of vaginitis. So annoying, actually. Wow. See, in this case, the patient doesn't have abnormal or mucopurulent vaginal discharge. I don't know what I'm seeing here. Okay, let me give them a feedback. Where's the...
Send us a feedback about this stupid question. Or not, let's not say vaginal, like white cervical. Is that like the normal view of the cervix? Oh, that's an animal, right? I mean, maybe it's just the normal view. Okay. Yeah. Let me be more polite here. What is that white fluid on the cervix in the picture? Isn't that supposed to be discharge? Thank you. Submit. I'll show you guys they respond very quickly. Okay, I'm gonna stop here. I'm gonna get some food, and I'll watch the third lecture while I'm eating. So I think I didn't download the third lecture yet. Okay, not gonna be late.
Our next topic is physiology. Our next topic is physiology of lactation. And breastfeeding is unquestionably the best method of feeding babies. And I ask patients on their first prenatal visit, how are you planning to feed your baby? And the answer that I'm looking for is breastfeeding. And if they say, I'm not sure, say, then let me encourage you to breastfeed. If you have any questions, let's talk about that. This is the symbol for breastfeeding support, which is used internationally. Let's just briefly review breast anatomy. There are 15 to 20 lobes of the breast, and those are divided into lobules. These lobes are really the milk-producing units. They contain alveoli, which produce some milk. We'll show you a picture of that in just a minute. The ducts are the tubes that carry the milk from the alveoli to the nipples. Most of the breast is composed of adipose tissue. And a woman who has a large breast versus a woman who has a small breast, the difference is in the adipose tissue. And a woman who has very small breasts who says, well, I can't breastfeed, no, that's not true, because the majority of the size of the breast is from adipose tissue. The ligaments which support the breast, and the main ones are Cooper's ligaments, are what give the characteristic shape of the breast. And over time, there is changes which occur as a woman ages and matures. This is an image which shows the lobules of the breast, which are in dark. And you can see the ducts which carry the milk from the lobules, and they converge toward the nipple. And yet most of the breast is really fatty tissue. There are changes which occur with the menstrual cycle, with the hormones. Here you can see the alveoli, the collecting ducts, and here we have the adipose tissue. In terms of lactation, there are significant impacts of the various hormones. In terms of the development of the breast, estrogen at the time of puberty is what results in the growth of the ducts, the nipples, and the adipose. And this is discussed under the Tanner stages, which we talked about. Signify the collecting ducts. There are changes which occur with the menstrual cycle, with the hormones. Here you can see the alveoli, the collecting ducts, and here we have the adipose tissue. In terms of lactation, there are significant impacts of the various hormones. In terms of the development of the breast, estrogen at the time of puberty is what results in the growth of the ducts, the nipples, and the adipose. And this is discussed under the Tanner stages, which we talked about under the gynecology. Progesterone stimulates the growth of the lobules and the alveoli. So this is not the ductal system, this is the milk-producing area. Now, after delivery, the prolactin is important for the production of milk. And I should also say that in order for the engorgement to occur, estrogen levels need to drop. And they will drop when the placenta comes out. If there is lack of prolactin, milk will prolactin is important for the production of milk. And I should also say that in order for the engorgement to occur, estrogen levels need to drop. And they will drop when the placenta comes out. If there is lack of prolactin, milk will not be produced. The milk, remember, is produced by the alveoli in the lobules. When the baby suckles and stimulates the breast, there is a neural impulse which goes to the posterior pituitary and results in the secretion of oxytocin, which then results in contraction of the smooth muscles in the alveoli and the ejection of the milk. This image looks at the breast in utero at 8 weeks development, and all you have is a mammary bud. At 20 weeks, which is mid-pregnancy, we have a mammary cord. At birth, you can see that there are actually alveoli which are present. And it's not uncommon to see what is called sometimes witch's milk, which is being expressed or secreted through the nipples of newborns. A mammary cord. At birth, you can see that there are actually alveoli which are present. And it's not uncommon to see what is called sometimes witch's milk, which is being expressed or secreted through the nipples of newborns. And that is a consequence of the high levels of hormones in the mother. After the hormone levels drop with the removal of the placenta, you can see the prepubertal breast really has no alveolar tissue of any significance at all. With puberty, with the increasing estrogens and progesterone, we have the proliferation of the alveoli and of the lobules as well as of the ductal system. And look at the significant change which occurs with pregnancy. And particularly in the enhancement of the alveolar growth, because they're going to produce the milk. In women, they will increase the size of their breasts by up to 30%. Now, for some women, they say, wow, finally I've got something to show. But for women who start out with big breasts to begin with, this can become a major source of pain because of the support. Here we have the alveolar unit, and you can see the milk-producing cells which are around the lumen. This is the arterial blood supply, and this is where the oxytocin will come in, as well as the nutrients which are used to produce milk. When there is suckling and release of oxytocin, it is these myoepithelial cells which surround the alveolus, which causes contraction, expression of milk, which goes into the milk ducts, and off it goes to the nipple. And here we have a pregnant breast which is engorged, and you can see how full it is. All right, so that's the end of lactation. Our next topic, the breast, and those are divided into lobules. These lobes are really the milk-producing units. They contain alveoli which produce some milk. We'll show you a picture of that in just a minute. The ducts are the tubes that carry the milk from the alveoli to the nipples. Most of the breast is composed of adipose tissue. And a woman who has a large breast versus a woman who has a small breast, the difference is in the adipose tissue. And a woman who has very small breasts who says, well, I can't breastfeed, no, that's not true, because the majority of the size of the breast is from adipose tissue. The ligaments which support the breast, and the main ones are Cooper's ligaments, are what give the characteristic shape of the breast. And over time, there is changes which occur as a woman ages and matures. This is an image which shows the lobules of the breast, which are in dark. And you can see the ducts which carry the milk from the lobules, and they converge toward the nipple. And yet most of the breast is really fatty tissue. There are changes which occur with the menstrual cycle, with the hormones. Here you can see the alveoli, the collecting ducts, and here we have the adipose tissue. In terms of lactation, there are significant impacts of the various hormones. In terms of the development of the breast, estrogen at the time of puberty is what results in the growth of the ducts, the nipples, and the adipose. And this is manner stages, which we talked about under the gynecology. Progesterone stimulates the growth of the lobules and the alveoli. So this is not the ductal system, this is the milk-producing area. Now, after delivery, the prolactin is important for the production of milk. And I should also say that in order for the engorgement to occur, estrogen levels need to drop. And they will drop when the placenta comes out. If there is lack of prolactin, milk will not be produced. The milk, remember, is produced by the alveoli in the lobules. When the baby suckles and stimulates the breast, there is a neural impulse which goes to the posterior pituitary and results in the secretion of oxytocin, which then results in contraction of the smooth muscles in the alveoli and the ejection of the milk. This image looks at the breast in utero at 8 weeks development, and all you have is a mammary bud. At 20 weeks, which is mid-pregnancy, we have a mammary cord. At birth, you can see that there are actually alveoli which are present. And it's not uncommon to see what is called sometimes witch's milk, which is being expressed or secreted through the nipples of newborns. And that is a consequence of the high levels of hormones in the mother. After the hormone levels drop with the removal of the placenta, you can see the prepubertal breast really has no alveolar tissue of any significance at all. With puberty, with the increasing estrogens and progesterone, we have the proliferation of the alveoli and of the lobules as well as of the ductal system. And look at the significant change which occurs with pregnancy. And release of oxytocin, it is these myoepithelial.
See that fourth lecture. Hi Doc, for how long are you going to study like this to see if I can set myself to follow the schedule? Every day. I'm going to do this every day for like 10-12 hours. All I care about right now is to get as high
Step 2 score as I can. So you got to do what you can do. Any hour in a day. So that's all I'm going to do. So
now I'm doing obstetrics. So if you followed the stream from the beginning, I'm doing obstetrics because I'm doing like all the questions wrong in Kaplan. So I'll finish obstetrics and then test myself with a like 69 questions and see if it's helping. If it's helping, I'm gonna do like every system like that and solve the questions on it, and then hopefully by the end of the month I'll finish all Kaplan QBank. After I finish Kaplan QBank, I'll go do Amboss and then New World. Maybe I'll do RX depending on like my speed. If I'm gonna go through it quickly, I'm gonna do RX too before doing U World, and then U World, CMS forms, MBMEs, I'll take the exam. Inshallah. Right, let's see. Physiology of lactation. Let's see that video. I'm gonna go get some water because I just ate.
Now we move into embryology. and Fetology. I want to look with embryology at week 1, 2, 3, and then 4 to 8. And it's important to note this is post-conception week. Now, obstetricians and physicians generally talk about the weeks of pregnancy using the term menstrual weeks. And we start the pregnancy with the beginning of the last menstrual period. Now, you realize, of course, in a 28-day cycle for the first 2 weeks, there is no pregnancy even there. So really, technically, the embryologists are more precise where they start dating the pregnancy from conception. So we're going to look at post-conception weeks rather than menstrual weeks. But remember, you can easily convert conceptional weeks to menstrual weeks by adding 2 weeks. So this would be menstrual week 3, menstrual week 4, and so on. For the first week. Embryology at week 1. Important to note this is post-conception week. Now, obstetricians and physicians generally talk about the weeks of pregnancy using the term menstrual weeks. And we start the pregnancy with the beginning of the last menstrual period. Now, you realize, of course, in a 28-day cycle for the first 2 weeks, there is no pregnancy even there. So really, technically, the embryologists are more precise where they start dating the pregnancy from conception. So we're going to look at post-conception weeks rather than menstrual weeks. But remember, you can easily convert conceptional weeks to menstrual weeks by adding 2 weeks. So this would be menstrual week 3, menstrual week 4, and so on.
Wait a minute. So what does conception means? Like specifically, I know what it means, but specifically, what does it mean? The action of conceiving a child, or a child being conceived. Okay.
We'll look at week 1, week 2, and week 3. Week 1 starts with ovulation and ends with implantation. We start with the egg, and here we have the zona pellucida, here we have the corona radiata. The egg is released from the ovary, and the site where it was released forms the corpus luteum, which produces progesterone. Here we have a number of eggs under the microscope. These eggs are the largest cells next to the neural cells in a woman's body. Here we have huge numbers of sperm, which are bravely seeking to fertilize this huge cell, small cells, with the large cells. And here you can see under a microscope as they're all trying to become the dominant sperm. Ultimately, only one is going to do it, in most cases. All right, we look at week 1 post-conception. And here we have ovulation, which is on a 28-day cycle where it usually occurs, day 14. We have fertilization, which occurs then within 12 to 24 hours of ovulation. We can divide the first week post-conception into 2 phases, the intratubal phase and the intrauterine phase. The intratubal phase is where we have the zygote. As it moves down the tube, it becomes a 2-cell, a 4-cell, an 8-cell, and so on. It is called, when it is a lump of cells, a morula. The morula enters the uterine cavity in the middle of that first week, and it develops a hollow core and becomes now what we call the blastocyst or blastula. So we have fertilization, the zygote which develops here, and we have the blastula which develops here. Now what is interesting, if we have twinning which occurs in the first half of the first week, it will be a dichorionic, diamnionic placentation. We'll talk about this later. If we have twinning which occurs after the blastula is already developed, it is a splitting of the inner cell mass, and now we will have a monochorionic, diamnionic placentation. So here we have the 1-cell stage, which becomes the 2-cell stage, which becomes the 4-cell stage. Okay, you've heard about stem cell research. This is the morula. And if you take one of those cells from the morula, each of those cells is totipotential. And you can do pre-implantation genetic diagnosis on one of these cells, and you will not interrupt the normal sequence of development. So here we have the blastocyst. It is a outer core of trophoblastic cells, and we have the inner cell mass, which is known as the embryoblast. This will then, at the end of the first week, implant onto the endometrial cavity. So here we have ovulation, which occurs. Fertilization typically occurs in the distal tube, and we have the 1 cell, the 2 cell, the 4 cell, and so on, and the morula enters into the uterine cavity and becomes the blastocyst. So in some cells, and we have the inner cell mass, which is known as the embryoblast. This will then, at the end of the first week, implant onto the endometrial cavity. So here we have ovulation, which occurs. Fertilization typically occurs in the distal tube, and we have the 1 cell, the 2 cell, the 4 cell, and so on, and the morula enters into the uterine cavity and becomes the blastocyst. So in summary, the morula develops week 1, the blastocyst develops week 1. Okay, and so now we move to post-conception week 2. Post-conception week 2, if you can remember, 2 layers in the germ disc, bi-2, formation of the bilaminar germ disc. And here we have the blastula as it is approaching the endometrial surface. Here we have the maternal sinusoids, which the trophoblast is going to be heading for. It wants to invade those. And this is what happens at the end of week 1. And here we have the implantation, which has occurred. And if you look carefully here, you can see the 2 layers, the hypoblast and the epiblast. And here is our trophoblast. This is the syncytial trophoblast and the cytotrophoblast.
That's week 2.
Here you can see a little bit better. The 2 layers, we have the epiblast, the hypoblast, we have the cytotrophoblast and the syncytial trophoblast, and the syncytial trophoblast is heading for the blood vessels. This is in the 2nd week. This is another picture from Gray's Anatomy, which shows the 2 layers. We have the hypoblast, the epiblast. Here we have the cytotrophoblast and the syncytial trophoblast as they are invading.
You're welcome.
So, in summary, the 2 germ layers develop week 2, and once the syncytial trophoblast invades into the maternal sinusoids, the beta-HCG, which is produced by the syncytial trophoblast, now becomes detectable in the maternal blood week 2. All right, we move to week 3. Week 3 is a formation of the trilaminar germ disc. So bilaminar germ disc week 2, trilaminar germ disc is week 3. And here we can see a cross-section of the early developing embryo. This is the epiblast, which will become the ectoderm. This will be the mesoderm, and this is the hypoblast, or which will become the endoderm. So we have the 3 layers which are forming here. Again, ectoderm, mesoderm, endoderm. This is a rat embryo, and you can see the ectoderm on the top, the endoderm on the bottom, and the mesoderm, which is in the middle. This is day 18 post-conception, which is the 3rd post-conceptional week. Again, the zygote, week 1. Blastocyst implants, week 2. The 3 germ layers forming, week 3. And this just shows the derivatives of each of the layers, the ectoderm, the mesoderm, and the endoderm, and this is all step 1 stuff. I don't think they're going to ask this on step 2. So the 3 germ layers develop on week 3. Step 1 stuff. I don't think they're going to ask this on step 2.
It's a nice table. Week 1, morula, blastocyst. And week 2, 2 germ layers, beta-HCG becomes positive, and week 3.
So the 3 germ layers develop on week 3. Week 4 to 8 is now set in motion for the formation of the major organ systems. And you cannot develop any of the organs until you have the 3 germ layers which have developed. So there is really no chance for teratogenesis unless you have the 3 germ layers. And that develops week 3. And so when we look at the major impact of teratogenesis, whether it be from medications or radiation or hyperthermia, it's going to be weeks 4 to 8. Now think of this. If these are post-conceptional weeks, in menstrual weeks, this is weeks 6 to 10. Now, when do most women present for their first prenatal visit? How many weeks gestation? It's not uncommon to see 8 to 10 weeks, menstrual weeks. By that time, the organ systems have already developed. There is probably little you're going to do to prevent any malformations by that time. So this is very early when these impacts will have their effect. Okay, embryology of the female reproductive tract. Our main concern is the Müllerian or the paramesonephric system. Here you can see the kidney over here, which is the system. Very little you're going to do to prevent any malformations by that time. So this is very early when these impacts will have their effect. Okay, embryology of the female reproductive tract. Our main concern is the Müllerian or the paramesonephric system. Here you can see the kidney over here, which is the derivate, or what the kidney will be derived from. And here we have the paramesonephric duct, which will become the Müllerian duct. And you can see there's two of these. This one is cut off. But you can see how close the kidney and the paramesonephric duct are. The impact of this is that if you have a malformation which occurs in the Müllerian system, be alert that you may very well have a malformation also of the kidney or of the urinary tract. So the Müllerian and the urinary tract develop very, very close to each other. This is showing the close relationship in the undifferentiated embryo of the Müllerian duct here and of the Wolffian duct. Now the Müllerian duct will develop into the uterus in a female. The Wolffian duct will develop into the male internal reproduction.
The way I remember it is that wolf is like masculine and Müllerian is, is a woman.
Organs. The Müllerian duct is initially double, and it fuses. And the fusion of the Müllerian duct produces the oviducts, the uterus, the cervix, and the proximal vagina. Here's another way of looking at it. The Müllerian duct fusion gives rise to the oviduct, the fimbria, to the corpus of the uterus, to the cervix of the uterus, and to the proximal vagina. So if we have a complete androgen insensitivity, or Rokitansky-Kuster-Hauser syndrome, where you have failure of the Müllerian duct to develop, what is missing? We will have the fallopian tubes missing, we will have the corpus of the uterus, the cervix, and the proximal vagina. Those are missing with Müllerian agenesis. The early anatomy of both the female and the male is identical, the external anatomy. And when you look to a very early embryo, you really couldn't tell whether it's a male or female. The differentiation of the external genitalia is very much impacted by hormones, particularly in the male. In order for the male external genitalia, for the penis, for the scrotum to develop, you need to have androgens present. Is there any hormone which is needed for differentiation of external female genitalia? And the answer is no. In fact, you can have, with androgen insensitivity, a genetic male, but who develops female external genitalia, mainly because there are no receptors for androgens. Is very much impacted. The early anatomy of both the female and the male is identical, the external anatomy. And when you look to a very early embryo, you really couldn't tell whether it's a male or female. The differentiation of the external genitalia is very much impacted by hormones, particularly in the male. In order for the male external genitalia, for the penis, for the scrotum to develop, you need to have androgens present. Is there any hormone which is needed for differentiation of external female genitalia? And the answer is no. In fact, you can have, with androgen insensitivity, a genetic male, but who develops female external genitalia, mainly because there are no receptors for androgens. All right, this is a kind of a busy slide, but I think it'll make it clear, and it's quite simple. We're looking at what hormones are needed for female genital development, what hormones are needed for male genital development. In terms of external genitalia, what hormones are needed to form the labia? And the answer? None. What hormone is necessary for proliferation and development of the Müllerian duct? None. What hormone is necessary for, in a female embryo, for the Wolffian duct to involute? And the answer is none. So the default differentiation in an embryo, unless there is something which determines it moves in another direction, the default differentiation is going to be in the female direction. What is necessary for external genitalia to form in the male? DHT, which is the most potent androgen, dihydrotestosterone. That is needed to form the external genitalia, the penis, and the scrotum. What is necessary for proliferation of the Wolffian duct internally? Androgens, testosterone is necessary. What is needed in order for the Müllerian duct to involute in the male embryo? Müllerian inhibitory factor, which is produced by the testes. So you can see that the default differentiation is female because there are no hormones which are needed. That's the way it will automatically go. In order for male genital development, DHT to form the external genitalia, androgens to proliferate the Wolffian duct, and Mullerian inhibitory factor for the Mullerian duct to atrophy. When you have complete androgen insensitivity, you will have failure of the Wolffian duct to develop because there are no receptors to the androgens. But the Mullerian system will involute because the testes still produce Mullerian inhibitory factor. This is in your notes, looking at the Wolffian duct. In the testes, we have the Sertoli and the Leydig cells. The Sertoli cells produce Mullerian inhibitory factor, which cause involution of the Mullerian development. And so you have no uterus, no ovaries, no cervix. The Leydig cells produced testosterone, and those will cause virilization of the external genitalia as well as maintain the Wolffian development. And so we have the development of the seminiferous tubules and the vas deferens. The testosterone is converted by a 5-alpha reductase enzyme into dihydrotestosterone, which is the most potent androgen, and those will bring about virilization of the external genitalia. And some cells which cause a Wolffian duct. In the testes, we have the Sertoli and the Leydig cells. The Sertoli cells produce Mullerian inhibitory factor, which cause involution of the Mullerian development. And so you have no uterus, no ovaries, no cervix. The Leydig cells produced testosterone, and those will cause virilization of the external genitalia as well as maintain the Wolffian development. And so we have the development of the seminiferous tubules and the vas deferens. The testosterone is converted by a 5-alpha reductase enzyme into dihydrotestosterone, which is the most potent androgen, and those will bring about virilization of the external genitalia. Okay, let's now turn to teratology. And we're going to look at the definition, the stages, and the types of agents. A teratogenic agent is anything which disturbs normal development and affects subsequent function. This could be a drug, it could be a energy source, such as X-radiation, or it could be hyperthermia. What is interesting is that the effect of a teratogenic agent is very much time dependent. There are certain gestational ages where certain teratogens will have their impact. If you wait until after that, even a few days, it will have no effect at all.
Wow.
Right, we've already agent is very much time dependent. There are certain gestational ages where certain teratogens will have their impact. If you wait until after that, even a few days, it will have no effect at all. Right, we've already looked somewhat at the stages of teratogenesis. This just reviews what we've already said. What is the effect of a teratogen on the embryo by gestational age? From conception until the end of week 2, there is nothing. It will either survive intact or it will die. And the reason is because there are no germ layers. Because it's not until week 3 and further that you have the 3 germ layers. So prior to that, intact, survival, or if there is effect which is severe, the embryo will die. Post-conception, weeks 3 to 8. Now here's where we have the risk. And week 3 is really pretty minimal. You've got to have the 3 germ layers in order for there to be a possibility for teratogenesis, because that's the germ layers. 8 conceptional weeks or 10 menstrual weeks, all of the organs have formed. After week 8, we're going to have either hypertrophy or hyperplasia, and those are post-conception weeks 9 plus. And what is, I think, very fascinating is the resistance of this early fetus to external influences. They have either hypertrophy or hyperplasia. Conceptional weeks or 10 menstrual weeks, all of the organs have formed. After week 8, we're going to have either hypertrophy or hyperplasia, and those are post-conception weeks 9 plus. And what is, I think, very fascinating is the resistance of this early fetus to external influences. Here we have a patient who is our case. 36-year-old woman, underwent a barium enema for rectal bleeding on February 1 with an estimated radiation dose of 4 rads. Her last menstrual period was January 1. She has 35-day cycles. All right. She had her last period on January 1. If she had her last period on January 1, if she had 28-day cycles, when would she ovulate? She would ovulate on day 14. If she has 35-day cycles, what day did she ovulate on? Okay, if we increase the length of the cycle, it is going to be the pre-ovulatory phase which lengthens. She will have a conception, I should say ovulation, which occurs 14 plus 7, which is 21 days. She ovulated on day 21, which would be January 21. Okay, the exposure of the radiation was February 1. So she ovulated, probably conceived on January 21. How many weeks post-conception was the exposure to the barium enema? In the second week. What's the impact going to be? It's either going to be intact survival or it will be death. Now, when we look at the radiation dose, 4 rads, what is the threshold at which we see significant impact? It's going to be 10, 5 to 10 rads. So for 2 reasons, we can feel quite comfortable with this fetus. Number 1 is the exposure occurred in week 2, and the second is that the radiation dose was pretty minimal. She was not using any contraception. A urine pregnancy test was positive. It's either going to be intact survival or it will be death. Now, when we look at the radiation dose, 4 rads, what is the threshold at which we see significant impact? It's going to be 10, 5 to 10 rads. So for 2 reasons, we can feel quite comfortable with this fetus. Number 1 is the exposure occurred in week 2, and the second is that the radiation dose was pretty minimal. She was not using any contraception. A urine pregnancy test was positive on March 15, which is what you'd expect. What is the risk to her fetus of teratogenic injury? And the answer is basically minimal, if any. So she can be reassured. Okay, let's look at various agents that result in...
Okay, so said at least 10 rads that would affect teratogenesis. He said that pre-ovulatory cycle, pre-ovulatory phase of the menstrual cycle is the one that elongates. So if she has normally, if she last menstruating was January 1st, ovulation is going to happen about 14 days, right? If her cycle is 35 days, she's going to ovulate 21. So add 7 days. Yeah, add 7 days. So if she ovulated January 21st, this is basically 1 week. About second week, so February 1, all right, yeah, second week. We said second week is intact or death, complete death. Okay. All right, so so we said menstruation happens, then wait 14 days, ovulation happens. Yeah.
If any. So she can be reassured. Okay, let's look at various agents that result in teratogenesis or adverse outcomes. The radiation dose, if you look at exposure, which is less than 5 rads, there's basically no significant risk. Even up to 10 rads, the risk is minimal. When we're looking at significant dose of exposure, we're looking at 10 rads or more. And when you look at almost all of the diagnostic modalities that we use, whether it be a chest x-ray, whether it be a abdominal CT, whether it be a IVP, even barium enemas, usually will not go over 10 rads. So when a woman has been exposed early in the pregnancy to radiation, what is the likelihood that she should be advised to terminate the pregnancy because of teratogenesis? Almost never. Almost never. It's amazing the resistance and resilience of the embryo and of the fetus to chemotherapy. Let's say that she develops leukemia in the first trimester or in the second trimester. What is her risk? The fetal risk from chemotherapy is highest in the first trimester, which was what you'd expect, but even then it is only 20%. In the second and third trimester, the risk is about 5%, which is no different from the general population.
Wow.
So the primary risk is in the first trimester. Obviously, we'd rather not use it any time in the pregnancy, but it's primarily in the first trimester. It is gestational age dependent. Now let's look at some specific prescription drug syndromes. One different from the general was what leukemia of teratogenesis. Almost never. Almost never. It's amazing the resistance and resilience of the embryo and of the fetus to chemotherapy. Let's say that she develops leukemia in the first trimester or in the second trimester. What is the risk? The fetal risk from chemotherapy is highest in the first trimester, which was what you'd expect, but even then it is only 20%. In the second...
Makes sense, because in the first trimester you have like a lot of stem cells dividing,
So, yeah.
In the third trimester, the risk is about 5%, which is no different from the general population. So the primary risk is in the first trimester. Obviously, we'd rather not use it any time in the pregnancy, but it's primarily in the first trimester. It is gestational age dependent. Now let's look at some specific prescription drug syndromes. First, I just want you to notice on this, actually this is an advertisement from Pfizer, and it looks at the lips, and the reason is because you're supposed to love the diflucan, which is fluconazole. But I want you to notice what is called Cupid's bow here. You see this Cupid's bow? That, and here again is the Cupid's bow. You don't see that in children who have fetal alcohol syndrome. They have a loss of Cupid's bow, and they also have a long philtrum. Now this is the philtrum right here, from the bottom of the nose to the top of the lip. You see on this one child here, a long philtrum, and you have the absence of Cupid's bow. Smooth philtrum. Now here's a child who has a nice Cupid's bow. You see this Cupid's bow right over here? Isn't this a beautiful child? Well, of course. This is my grandchild. And here she is a few years later. There's a lot of other stigmata of fetal alcohol syndrome, which we don't need to go into. In your notes, you'll notice that there are in the italics, the most common findings that we will see with the various syndromes. I might say that fetal alcohol syndrome is one of the most common preventable causes of mental retardation in children. DES, what does DES stand for? Diethylstilbestrol. Diethylstilbestrol is a non-steroidal estrogen which used to be used in years past to try to prevent pregnancy loss when there was bleeding in the first trimester. Now, what is the most common cause of first trimester loss? We know it's aneuploidy, abnormal chromosomes. What can you do to change that? Basically nothing. And yet this is what we used. What are the impacts in a teratogenic way of diethylstilbestrol? Here we have a normal-shaped triangular uterine cavity. With a DES-exposed uterus, what do you see? A T-shaped uterus. That would be worth remembering for the boards. Another finding, which is probably more serious, is increased risk of clear cell carcinoma. There's also adenosis, which is columnar epithelium, on the exocervix and on the vagina. The Mullerian...
Okay, T-shaped. T-shaped uterus. Diethyl still.
With basic trimester. Now, what is the most common cause of first trimester loss? We know it's aneuploidy, abnormal chromosomes. What can you do to change that? Basically nothing. And yet this is what we used. What are the impacts in a teratogenic way of diethylstilbestrol? Here we have a normal-shaped triangular uterine cavity. With a DES-exposed uterus, what do you see? A T-shaped uterus. That would be worth remembering for the boards. Another finding, which is probably more serious, is increased risk of clear cell carcinoma. There's also adenosis, which is columnar epithelium, on the exocervix and on the vagina. The Mullerian anomalies, which you see with DES, are significant enough that the American Fertility Society has given a separate category for DES-related Mullerian anomalies. Here we have a hysterosalpingogram of a normal uterus, and you notice the triangular shape. Here we have a DES uterus, a T-shaped uterus. And unfortunately, many of these women, and you notice the triangular shape. Here we have a DES uterus, a T-shaped uterus. And unfortunately, many of these women will have early deliveries of babies or even have failure for conception to occur. This is an advertisement from an OBGYN journal about 50 years ago. And it's quite remarkable in how it is promoting the use of DES. This is what it says. It's hard to read. 96% live delivery with DES Plex in one series of 1,200 patients. Bigger and stronger babies, too. What's the message? You want to have a strong, big baby? Why, take DES. Can you believe this? This was in 1957. And now we realize this was crazy. We should never have done this. And it makes me think, as we move on in our understanding in years to come, looking back now, we will probably say, that was so stupid. Let me give you another example of this. These are some advertisements that were in the media decades ago. 20,000 physicians say Luckies are less irritating. What's the message? Why, your doctor smokes, so you should smoke. And now we know very clearly that 1/3 of people who smoke will die from that. Okay, dilantin phenytoin. Notice the face of this child here. Craniofacial dysmorphism is found in the dilantin teratogenesis. Notice these babies, our children, are unrelated and that they have the same pixie-shaped nose here. Craniofacial dysmorphism. This would be an important one for the board exam. Not that this causes any significant impact in function, but notice the tiny, small nails. Fingernail hypoplasia is seen with dilantin phenytoin syndrome. Isotretinoin. What is the trade name for isotretinoin? In this pixie is found. Okay, your doctor smokes, so you should smoke. Notice the face of this child here. Craniofacial dysmorphism is found in the dilantin teratogenesis. Notice these babies, our children, are unrelated and that they have the same pixie-shaped nose here. Notice the craniofacial dysmorphism. These babies out here, 1/3 of people who smoke. Craniofacial dysmorphism is found in the dilantin teratogenesis. Notice these babies, our children, are unrelated and that they have the same pixie-shaped nose here. Craniofacial dysmorphism. This would be an important one for the board exam. Not that this causes any significant impact in function, but notice the tiny, small nails. Fingernail hypoplasia is seen with dilantin phenytoin syndrome. Isotretinoin. What is the trade name for isotretinoin? Accutane. Accutane. This is used by what age patients? Typically, it's going to be used by teenage female patients. And some of the concerns that we have with isotretinoin is small ears, microtia. You can see how small this ear is. What is this right here, do you think? This is a cochlear implant because there is eighth nerve problems also with isotretinoin. Now, this is talking about systemic. This is oral, not the topical. There are also, this also shows the ear malformations which can occur. Unfortunately, it's not just the ear. There are all kinds of other malformations, particularly of the heart. And the FDA, Food and Drug Administration, is very concerned about this and bringing about some major restrictions on the use of Accutane. If a patient wants to use Accutane, they have to pledge that they are going to follow certain guidelines or they will not be prescribed it. They have to use simultaneously 2 forms of contraception. They have to have 2 negative pregnancy tests. One must be in a laboratory, so not just home pregnancy test. They have to go online to answer questions on their reproductive life. They are given only 1 month's supply of medications, and they have to certify that they are using 2 methods of contraception, and before they can get a second supply for the next month, they have to have a negative beta HCG. This is a major concern, Accutane birth defects. Now, of course, if you have a baby that develops Accutane problems, what do you do? What is the American way? The American way is sue. So you sue the company, you sue the doctor. And this is the license plate of an attorney who lives down my road. I sue for you. Isn't that sweet? Accutane must not be used by female patients who are or who may become pregnant because of severe birth defects. Okay, another teratogen is lithium. What is lithium associated with? Epstein anomaly. Here's Epstein anomaly. This is a normal right atrium and right ventricle. This is the tricuspid valve. It is downward displacement of the tricuspid valve leading to a large left atrium. Epstein's anomaly associated with lithium. Here we have tetracycline. What does tetracycline do? Deciduous teeth discoloration. Now, your friendly dentist will be more than happy to whiten your teeth. This is not a major anomaly, but it's one that could be very well on the board exam, so you should know it. It is really where you have the calcium is being displaced by the tetracycline. And here you can see the tooth discoloration also. So we don't use tetracycline during pregnancy. Here is a good board question. Thalidomide. What does thalidomide cause? Phocomelia, limb reduction. And you can see the short extremities here. And on this cartoon character here, we have short extremities on both the upper and lower limbs. Thalidomide used to be used for nausea and vomiting in pregnancy, and it was very effective. Very effective. It was used widely in Europe, but it was not allowed in the United States. And that was fortunate. The interesting thing about thalidomide was that the teratogenic effect was only between day 42 and 48. There was a narrow window of time. And if the exposure occurred either before or after, there'll be no impact. It's an excellent drug. But during these critical periods of time, it led to major risks. Now, thalidomide has been reintroduced into the United States for use to treat leprosy and multiple myeloma. A lot of discussion by the FDA before they allowed it to be used because concerned that it might get into the hands of pregnant women. Here you can see on this image a very short proximal extremity here. And here you can see focomilia also. Valproic acid, the trade name is Depakote. This is associated with neural tube defects. And interestingly, it's more likely going to be a spina bifida than it is to be anencephaly. It's also associated with congenital heart disease. And here you can see this neural tube defect right there. Valproic acid is used by many women and has been linked with birth defects, and probably more problematic than many of the other newer anti-epileptic drugs. For instance, lamotrigine, Lamictal, is probably much safer than valproic acid. And so doctors are urging women not to use valproic acid if they are in the fertile years. This is of concern to me. Depakote, or valproic acid, is used to treat bipolar disorder. It is used to treat migraines. And I wonder how many of these women who are taking this realize the impact potentially if they should become pregnant. Coumadin is an anticoagulant. It is taken orally. It has a small molecule. It can cross the placenta, and it can cause lots of birth defects, optic atrophy. It can cause problems with hemorrhage. But one which is a good board question would be chondrodysplasia punctata. And you can see here the calcification at the costochondral junction on this infant, this X-ray here. All right, that's the end of our embryology and fetology section.
Okay. Let me solve some questions. Which of the following is the most appropriate initial pharmacotherapy? Okay, painful urination and lower abdominal pain during intercourse. Okay. Right, so that's just UTI. She's not pregnant, so what do we give? There is no nitrates and cervicitis. Okay, so she has UTI, but her problem is cervicitis. I was gonna ask, like, what is the function of this sentence here? Then do cervical bleeding upon passage of a swab through the cervical os. Okay, this patient with dyspareunia, post-coital bleeding. Okay, fibral cervix, acute cervicitis, dyspareunia, post-coital bleeding, fibral cervix. Okay, makes sense. She's pregnant, 24 weeks. Okay, that's one of the risk factors. I need to watch the videos, obstetrics videos. Okay, I can't focus right now. I'm gonna take a break or something.
Thank you, Khalid. I appreciate it, bro. Okay, makes sense. Mullerian agenesis is very similar to complete androgen insensitivity syndrome because this guy has MIS, Mullerian inhibitory substances, so he inhibits the formation of Mullerian tube. Okay. The only difference is that the pubic hair here is fine. Sorry, here is fine, and here is non-existent. Tanner stage 2 pubic hair. Okay. And both presents with blinded and vaginal pouch. Both have normal external genitalia for a woman, for a girl. Okay.
This is her first pregnancy, bro. This is first pregnancy. How would she get that? Like, how would she be immunized? That's her first baby. Wow, it's recommended that all Rhd negative pregnant women undergo an antibody screen at the first prenatal visit. I'm from Egypt and in Masr, so I live in Buffalo now. Sorry, I didn't see your message. It got deleted for some reason. Did you send something? I just... perform antibody screen for anti-Rhd. Okay, so I guess we just do antibody on whoever, and then we see if we are gonna give her ROGAM or anti-ROD immune globulin at 28 weeks within 72 hours of any instance of fetal maternal hemorrhage. I'm sure that I saw a message here. Why is it? Is it being deleted automatically or what? I saw that you're إن أنت من كفر الشيخ في طب. أنت منور ربنا يخليك، بس مش عارف ليه اليوتيوب الزهري بيعمل يدلت الكومنتس بتاعتك. أنا معملتش حاجة والله، مش أنا. Okay, if the mother's serum contains significant titer, she's already alloimmunized. Anti-ROD immune globulin is ineffective in this case. Okay. So this question, every single question about like ROGAM, I got it wrong. So hopefully I'm not gonna get them wrong on the real exam. I'm taking it August, something like that. August, July, maybe. Hopefully, by the time I'm getting like a good score that I like, I'm proud of. But it's honestly, it feels far. Like I have some OB-GYN. Like I'm very bad at it. I didn't attend the lectures and rounds in med school. Really? Congratulations. Did you get your score yet? Come help me, bro, with this, with the OB-GYN shit. Sorry, there's latency when you send a message. I see it later, I think. Or you see my video late, something like that. Inshallah, I'll get high score, bro. Good luck. What was your MBME before? Like, before your exam? Mashallah, that's good. Where are you from? And did you come here, like, to the US or no? Are you an IMG medical student? Like, tell me about yourself. Did you come here to the US yet, or are you still in med school? That's good. I have the US citizenship too. I'm actually so tired. I finished 40 questions, and then about 60, let's say 60 questions. I watched a lot of Kaplan videos. Nashville, so that's in Tennessee, right? Nashville? Nashville. Yeah, Tennessee. I have a friend there too. Okay, so when are you gonna apply for the match? Inshallah. And when did you graduate? '21. Oh, okay. That you're a fresh graduate. I literally just graduated, like 2023. How's Nashville? Is that good? Or I'm in Buffalo. I'm in New York. It's cold here. Yeah, same actually. I'm just waiting to finish my step 2 and hopefully I get a good score and then apply for research positions. Step exams are they're so annoying, bro. It's insane. It's crazy. Hey, come on. High five. I want orthopedic surgery too. You're probably jacked, aren't you? I mean, if you could, like, you're ready. If you've just taken step 2, you're ready for step 3. Just take it. Yeah. Step 3 would be helpful, I guess, in addition to research. Holy shit, no way. No. Not like Manhattan at all. It's just, it's like, do you know Albany? Albany, New York, like the capital of New York City, like New York State. Not like Manhattan. Manhattan is crowded and it's different. It's a different story. But wow, there's actually a huge delay, like when I'm talking and it reaches you. Okay, I'm gonna wait for your messages then. I'm gonna finish these 4 questions. I've been following you since your interview with that mate who scored 277. I really admire you. I appreciate you, man. Thank you so much.
Wow, since like 2 years you've been following us, so you've seen all the garbage. I really appreciate it. What's your name? And why is your name programming for life? You're a medical doctor. Why do you have a programming for life name? I bet what you're doing, like what you were doing after graduation, is programming, isn't it? Oh, okay, you're a smart dude. I mean, programming is like, it's not fun at all, right? It's like the opposite of fun, or I guess you disagree with me. I don't know. I yawned for like 10 times. I was a girl. Pregnancy is complicated. Come on. Oh no, that's pure obstetrics. NYC only been to Brooklyn and Manhattan. Okay, so you're American, so of course you know that there's New York State. There's New York State, and there is New York City. What you've been to is New York City. You typed it NYC, so you probably know that. I'm in Buffalo, so I'll show you. Buffalo. Oh no, never mind. So yeah, so this is Albany. This is the capital of New York State. This is Buffalo. This is where I am at. And this is New York City, I guess. Yeah, this is New York City. I'm right here. I used to live in Albany before, but I moved to Buffalo. So, yeah. Because my brother is in dental school here in Buffalo, University of Buffalo. My brother is doing... He finished his Master's of Architecture. He's working here as an architect in Buffalo. So we had to move here. Yeah. Okay, this question, I have no clue. I don't think I'm gonna get it right, so let's just mark it. I'll solve it after I watch the Kaplan videos. Which of the following is the most likely diagnosis? Okay, that's overflow incontinence because he still has. Really, step 3 is like a pain in the ass. It's really been. Yeah, bro. It's crazy. When I knew that it's 2 days, like 2 consecutive days, like 8 hours and 9 hours, I was dead. It's so insane. Like, even the fact that, step 2 is 8 hours, I don't want to take it. That's like torture, for sure. Like, I gotta build the stamina, I've been studying almost the entire day today and yesterday. And hopefully I'll, like, continue like that till the exam. But, like, whatever. Like, we gotta do that. There's no excuses, so... Alright, let's just overflow. Okay. Is better than step 1. I'm getting all the questions wrong, see? Like all the OB-GYN questions, I'm getting them wrong. I mean, step 1 was way easier to me. Like, what do you mean by it's better than step 1? Terms of preparation. I mean, I can see a lot of like screening guidelines and a lot of treatment guidelines that are so weird. Like, I gotta learn all that. Like, it's memorization heavy, you know? Like, it's either you know it or not. No, this guy hasn't taken step 2 even yet. He's planning to take step 2 in August, I think. Yeah, he didn't even apply for residency. Like, it was like year 4 when he took step 1. So we just graduated together. He's preparing for step 2 now, right now, just like me. He wants plastic surgery. Like, I think he deserves that so much. 24-year-old woman comes to the clinic because of loradone. Non-foul smelling. Okay, that's cervicitis. I just got this question wrong before. So let's give her single dose IM ceftriaxone and doxycycline for 2 weeks. Okay, got this right. Probably should have done an elective. You mean me? Or him? Or who? To be honest, I mean, I don't know what specialty I want yet. Like, you know, when you just want orthopedic surgery, but you're not sure if you want orthopedic surgery, and you're still gonna work so hard for it. So I don't know what specialty I want. So that's why I don't know what elective to apply for. Is it surgery? Is it internal medicine? I don't know. Him, he doesn't have a visa, so he has a problem coming here. He's trying to get a visa to come here, and then like all the opportunities will open for him. But he has to come here first. So. Administration of which of the following is the best next step in management? Ultrasound shows a fetus in cephalic presentation. Okay. Administration of which of the following is the best next step in management? 9-year-old woman, gravidarum 1. Okay. It's taking vaginal progesterone and the patient. Tocodynamometry shows no contractions. Sterile speculum shows a pool of clear fluid in the posterior fornix. Yeah, okay, so A swab of the fluid turns. Okay, that's oxytocin, I guess. But you gotta give him, like, there is no love lost between you and OB-GYN. No, like, I lost it, really. Like, I hate it right now. I always hated it, by the way. That's why I didn't attend the course at med school. I always hated it. But, like, I'm hating it right now more, you know? Damn. Okay, tocodynometry shows no contraction, so I guess you gotta. So, how's your preparation for step 1 like? What did you do till the day of the exam? How did the exam go? All right, I'll tell you. So, I did all boards and beyond. So I watched all the videos and I did the Anki forum. And I didn't start doing questions. Like, I was procrastinating so much. I did just like 14 blocks of UWorld, and then very random stuff, So I did like some of the RX questions. I did 14 blocks of UWorld, and before the exam I finished AMBOSS. Like, even I didn't finish it, like 70%, 60% of it. And then I found myself getting like 250s on the MBMEs. So it was that was it. And so I got in, I finished it. I was fasting that day. It was the last day from Ramadan. And the exam went fine. I passed, alhamdulillah. It was easy. Okay, so I'm tutoring right now for step 1, so I have like a course I'm tutoring people like one-on-ones. I do one-on-ones. So depending on like the meeting, but otherwise I just study. And I go to the gym sometimes too, but you know my car broke, so I'm like stuck at home. And then yeah, I figured, you know, I could just stream my USMLE Step 2 preparation just to you know, document my life, I guess. To like, a lot of people ask me how to study and stuff, and I'm just showing them how I study. And I just got a new camera. Like, do you know GoPro? I just got GoPro, which is like nice, you know. I'm planning on doing some vlogs too. Like, I don't know how that will turn out to be, but you know, my life is boring right now, but I gotta figure out how to make it fun, I guess. I think the second step is like giving amniotic fluid. Like, when do you give amniotic fluid in a patient with pre-ROM, you know? Or are we gonna deliver the baby? I thought we're gonna deliver the baby, so we give him like choice E. Labor induction is generally indicated for pre-ROM at more than 34 weeks. Do a daily life of a guy studying for Step 2 and it will be fine for a channel. Actually, that was like something I would do, but I was just waiting for the camera. But literally, you know, I have zero. You know, it's so boring. Like, there's nothing in my day. So like, maybe in a week, like I'll just gather some situations, I guess, you know, and then gather them into a video. But yeah, that's a good advice. Thank you. A day in the life of a guy studying for Step 2. Yeah, what a day. What an interesting day. Labor induction is generally indicated for P-PROM at more than 34 weeks gestation for patients who have chorioamnionitis. So are you doing good in your med school in terms of grades? Or yeah, actually first year I got like very high. I was like I was ranking in my med school like applicants. After year one, what happened after year one? Yeah, I left medical school in Egypt. I came here to Albany to attend undergrad because I wanted to get into medical school in America. So I went for a semester here, like in Albany College of Pharmacy and Health Sciences. Let me show you. ECPHS. I went for a semester. I got a 4.0 GPA, but then I felt like I was dead. I felt like, you know, it's very difficult to get a 4.0. I was on the desk 24/7. I was eating shit. I got very like, I got a weight gain. Like I got very heavy at that time. I was depressed. I everything, and I had financial problems too. So I used to use the bus. I didn't have a car at the time. It was all crap, So I decided to go back. But then when I came back, in order to complete my medical school, I realized I have a complete semester I'm gonna finish along with like my schoolwork. So the second year was so bad. I think like the first semester was so bad. Like the second semester of the second year, I had to take the first semester along with it. So they were both very bad. Third year was COVID, so there was no grades. Fourth year was very good. I got a good grades. Fifth year, I was taking step 1, so I completely ignored OB-GYN. I completely ignored pediatrics. Like clinical, for me is so bad because I focused on step 1, and I was doing some business on the side, and I was doing this YouTube channel too. So not like the perfect, scenario for a medical student, but whatever. I'm trying to catch up. Sixth year, it was good, I think. Yeah. What did we take? Internal medicine and surgery. So yeah, that was like step 1 stuff. So yeah, I was chilling. I got excellent grade at that time. I think 90% or 80 something, 87%, something like that. So it was not that bad. And then yeah, I graduated. Damn, it's so hard to finish 80 questions. Oh my god. Like when you don't know the stuff. When you don't know the material, it's so hard to do even one block. I'm reading all the explanation, literally. All the explanation with all the answer choices. It's crazy. Where's my phone? When are you planning to sleep? I want to actually. I think I'm gonna just get another energy drink. I have to finish this block, or I feel like crap. Because my Kaplan is gonna expire in 20 days. So I have to finish at least 100 questions. And I have just done 60 for the entire day. Yeah, I'm gonna finish hi Ahmed. I'm gonna finish UWorld, but first I have to finish Kaplan. I want to finish all Q banks. So this is my first Q bank, so there's a lot of step 2 stuff I don't know. So I'm fine with just wasting a lot of time on these explanations. But at the moment I finish Kaplan, I will move very quickly through the other question banks. So I'll finish RX. Maybe I'll finish RX, I'm not sure. But definitely Ambos and UWorld and the CMS forums, I'll finish them. So I'm sure I'm gonna do maybe 3 blocks a day easily. But I just have to go through the material at least once, because all these information I have no idea about. I don't know. It's completely new to me. Like these management stuff and hello there. People scored 270 with UWorld only. Really? In my opinion, this is excessive. Who do you know? Do you know somebody who finished? Maybe these people, they had good foundation in med school. as I just explained to him, like the OB-GYN, a lot of the step 2 stuff, is Kaplan's Q-bank good for step 1? It is, yeah. Yeah, Yusuf Tanas, who got set 277 in step 2, did Kaplan Q-bank for step 1. Multiple people. Okay, ask these people that you know that they got 270 with your world only. How many Q-banks did they do for step 1? They were fresh out of step 1. Yeah, and I'm sure these people also, they didn't only finish your world. Like, they finished multiple Q-banks too. It's very difficult to get 270. It's not easy. What's your study material for step 2? Maybe I could ever help. Right now, I'm just doing Kaplan. That's it. Doing Kaplan, seeing the explanations. I would love to. Come on, man. Like, help me with that shit. Help me with OB-GYN. I hate it. Step 1, your world and amboss, and you're good to go, even half amboss. I mean, for passing the exam, yeah, for sure. Look, every to pass of your world would be better than doing 4 Q-banks. I disagree. I completely disagree. That's not true. I'll tell you why. Because when you do two passes of your world, you basically are not using your like, when you're doing questions, there's a process that happens. You're seeing different questions, different answer choices. You have active learning very well, but when you do 2 passes of your world, you gotta remember the questions. You're eliminating the active learning process. You're just the way you're solving questions is not by active learning or like by critical thinking. You just memorize, you know. You remember the buzzwords, you remember the answer choices, you just pick the stuff. So I disagree. No, doing 4 Q-banks is way better. I relied on Arabic sources for explanations, to be honest. Like who? Hosseini or Ayub? Or I know Hosseini. Can I go for step 2 at first without step 1 to get high mark like 260? My step 1 exam is on Tuesday, and then I'll start step 2 prep a week after. Good job. As soon as you finish step 1, come on, bro, do step 2 right away. I was doing a lot of, stuff along. If you're just planning to be a physician, you don't want business or any other stuff, just focus, finish the step exams quickly. The idea is that the second pass is random, first would be system-wise. You'll still be able to remember the questions. What's the point? Me too, I'm 100% against resolving your world. Exactly, bro. That's what I'm saying, yeah. Can I go for step 2 at first without step 1? I know people who've done it, yeah. I know people who have taken step 2 without going through step 1, and they did well. But, depending on where you're at right now, if you're doing clinicals and you feel like step 2 is targeting more of what you're already doing in medical school, then yeah, step 2 would be fine. But if you're like early, second, first year, go through the steps, like step 1, then 2. But I bet you're like a graduate or something. That's why you're asking. So yeah, that's fine. You can do step 2 first. I mean, do the questions. Do random questions. I'll show you guys. So here are my scores when I do random questions. I'm actually doing well. That's just because step 1. Oh damn, the Q-bank's not loading. Like I'm getting 70s. Hosseini's books for IM saved me, bro. Yeah, I think it's good. A lot of people say good things about Hosseini. Okay, never mind. Anyway, I was just trying to show you that I was getting 70s when I do random questions. But when I do like, when I do OB-GYN, this is my score. Like, I get half of the block wrong. That's why I'm watching Kaplan videos. I'm just too tired, actually. I don't know if I should sleep or get a like an energy drink and continue studying. I know, I'll see. Maybe I'll just sleep. I want my circadian rhythm to be fixed.
Let's move on to perinatal.
Are you gonna be applying for 2025 match? I mean, if I finished step 2 in August or like in 7th, I'll just apply for the match this year, hopefully, inshallah. If I didn't, I'll just focus on the business from 24 to 25, and then apply for the match 25. I once listened to your advice on a video that you should solve Q banks in parallel with medical school content and this divide feed families. Yeah, I did that with psychiatry. I'd recommend you get an energy drink, to be honest. You would recommend that I get energy drink instead of sleeping? Eid Mubarak, Naboy. I appreciate it, Omari. Thank you so much. I bet you're Yemeni, your name, Urduni, Jordan, right? Omar is not like Egyptian name. Omari. So Jordan, right? Jordanian? Perinatal statistics and terminology. Yeah, Jordanian, yeah. I'm actually so pissed. I just watched the Obstetrics, like I just watched the Kaplan video and I just got a question wrong about something I just watched the video about. I was so pissed. But then I understood the explanation. Well, it depends on when do you wake up. So today I woke up at 6 a.m. I did a stream for 2 hours and a half. I finished like 20 questions with reviews. And then I slept from 8:20 to like, wow, I actually slept a lot. I slept from 8:20 to like 2 p.m. So I want to wake up 6, but yeah, I come at like 8 a.m. and I want to sleep. So I couldn't focus. If you saw my stream in the morning, I couldn't focus at like 8:30. I was like, you know. You know what? I could actually get an energy drink. Because if I didn't do the 20 questions, like the rest, but the Q bank is not loading. It's saying error here. It's not loading, bro. Okay, anyway, I'm gonna get an energy drink based on your advice. I'll listen to your advice. 7-Eleven is like, yeah, I'll be streaming every moment I'm studying. I'll be streaming. So like in the morning, I'll be more focused. But like now I'm dead. So yeah, inshallah I'll be streaming every morning. Get some air and cold water. I have cold water here, but it's not doing anything. So I need the energy drink. You know what? See these two? I have 2 Red Bulls here. I'm looking for something like not anti-Palestine, you know, that's not supporting Palestine. Yeah, that's not anti-Palestine, but like the US is anti-Palestine. I don't know what to buy. Like in Egypt, I didn't buy like any like energy drinks, but like everything here supports against Palestine, really.
Here's a fact about me. I am a WWE fan. I had my step 2 today, and on Sunday I was in Philadelphia watching. Wait, you had step 2 today? Wait, I thought you wait. Oh damn, bro, you just finished step 2. Oh, that's so cool. Damn, bro, here's a high five. You did a great job. Good job, man. I get free U-World QBank for step 2. Where can I where can I get free U-World QBank? Okay, so this is I hope they don't use my use this against my channel, but here's Medicospira. Okay, I use this for step 1, and there's step 2 too. Just change the U-World 1 into U-World 2. Okay, and then you get the free U-World. But the problem is, okay, never mind. Just log in. I'll send you the link here. How can I just comment? Let me see. Okay, I'm gonna put it for 2 seconds and then remove it because the copyright is just gonna destroy my channel. Okay. Here. Alright, so here it is. Okay, I cannot I'll put in the chat. I'll just remove it right away because I don't want to get banned. You can get free U-World from here, but here's the problem. If you can purchase the real U-World, it will be good for you, because here you only can do 40 questions for 5 blocks, and then after that you only can do 5 questions per block. So what you will do is that you cannot do blocks anymore. So you can do time blocks, and you can repeat like, you know, the questions. If you want 40 questions a block, you'll do new accounts, and the old questions that you already done will show up again. So it's not helpful. You're welcome though. I'm gonna move again. will show up again, so it's not helpful. You're welcome though. I'm gonna move again. By the way, what is your phone type? Because that's a cool camera resolution. Oh, this is not a phone. This is a $350 camera. Do you know? Let me show you the. One second. See this? It's Elgato. It's called Elgato Facecam Pro. It's like very expensive for some reason, but it's very nice. I think the resolution would be even better if I put a ring light on. It will be better. It's 4K. I didn't use a phone because I thought it's gonna be too much friction. So every time I want to stream, I have to put the phone on and mount the phone, and you know, the battery will empty, so I'll have to recharge the battery and then put it again. So too much hustle. So I just bought this one. It's endless, so I don't have to recharge or whatever. عايز التاني. Hey bro, League منورة دي. No bro, that shit is over. I'm not gonna play this game again. فين دي؟ ليك فين؟ Okay, alright guys, I'm gonna go get an energy drink and finish these videos, right? If you guys are gonna sleep, good night. If you're gonna wake up, yeah, I'll be back in 10 minutes.
and terminology. The first thing we need to do is just to define some of these terms. Gravidity is the total.
Yeah, can you hear me now? Sorry. I just figured my my dad took the car. Like, he took my mom to the hospital because she's sick. And my car broke, so I just made a coffee at home. I mean, it's caffeine at the end of the day, right? So it's gonna do the job. Bismillah.
Total number of pregnancies, regardless of duration or the outcome. Parity is where you have a pregnancy that goes longer. Let's look at perinatal losses. Parity terms. Gravidity is the total number of pregnancies, regardless of duration or the outcome. Parity is where you have a pregnancy that goes 20 weeks or longer. Let's look at perinatal losses and perinatal loss rates. This is in your notes, and we look at various concerns. We look at fetal mortality rate, neonatal mortality rate, perinatal mortality rate, infant mortality rate, and maternal mortality rate. What we're looking at with birth rate is a number of live births. With fertility rate, we're looking at live births also. But if you'll recall...
Is there any way I could talk with you on this platform? Do you have Discord? I have Discord, if you want to like speak with me like sound. What's your Discord? Send me your Discord user. If you have Discord. I actually have like a Discord group. Like there is MD in the making community. There's a lot of people, but nobody's here, so I stopped posting a while ago. But if you're here, you could just join. You know what? I'll just join here so that to prove that I'm here. Let me send you the link to join if you have Discord. Copy. Invite people. Copy. Copy. Invite people. Copy. You can just join. QBank still doesn't want to open. Wow. Okay.
A rate has both a numerator and a denominator. So we have to look at the numerator and the denominator. All of these rates that we have here have a denominator of 1,000, with one exception, and that is the maternal mortality rate, which has a denominator of 100,000. And that's an important distinction for the boards. 1,000 for everything except the maternal mortality rate, which is 100,000. All right, Dan.
Did you get in? Just click here and we can talk. Oh, Sergo? There's like, what, 200 people. Nobody speaks on that server. It's my bad actually, because like I'm the one who they should follow, you know, but I'm not doing anything, so nobody's gonna do anything. Just join this room. Hey bro, can you hear me? I can't hear you. 1 second. Oh. Can you speak again?
So is my voice clear?
Oh yeah, I can hear you now. How are you doing? Yeah, your voice is clear.
Yeah, I'm just bringing my AirPods.
Oh, okay. How's it going, bro?
So I can bet that my sound is clear by now.
It is clear, yeah. I don't know if people can hear you, though.
Let me check.
Oh, yeah, people can hear you. Okay.
So, how's your preparation going?
Like what you're seeing now. I just started literally a month ago. So I'm about a month in, so I think I'm doing good. Like my baseline is 70% on Kaplan without any step 2 knowledge.
Yeah.
I'm pretty sure my knowledge.
Bro, I've never done Kaplan Q-Bank before.
What did you do?
I did UWorld, Ambos, RX.
For step 2?
Yeah.
Oh.
I feel like Kaplan is kind of very comprehensive.
You mean like a lot of non-important stuff or a lot of trivial stuff?
No, I'm speaking about Kaplan in terms of books, not Q-Banks.
Oh,
when I'm saying that's comprehensive.
Oh, like cover everything.
Like I feel it's like too much.
Too much. Okay.
Info. Yeah. Like I would recommend it if someone is just in his he's finished step 1 way early and is just beginning, like someone who doesn't have any sort of background.
Okay, I'll tell you why I'm doing Kaplan actually. It's crazy how much improvement I noticed when I did Kaplan microbiology and Kaplan immunology. Till this day, these are my strongest subjects. Like, they're very easy to me, immunology and microbiology. And they basically reflected also on my other like pathology preparation too. Like they improved my pathology a lot. So I'm basically using it for subjects I'm weak at. So OB-GYN, I'm pretty weak at. So I have no clue. Like I don't know what accelerations and decelerations mean. Just a week ago, I just knew that, you know. So I think it's gonna be helpful. At least
if I will speak about the material of step 2, I would say that I had a strong background back when I was in medical school in terms of internal medicine, surgery, pediatrics.
Mm-hmm.
Like we really, in our medical school back, we really like dove deep into the info and the content of every single subject.
Yeah.
You feel me? I believe that you did so, but you were telling me that you had you were doing step 1 at the time, so you didn't have enough time to like study OB/GYN and pediatrics.
Correct. Yeah, that's exactly what happened.
So if that's the case, then I believe that Kaplan will be like the best for you.
Correct. I'm feeling it's good actually. I didn't even get into like serious step 2 material. I'm pretty sure it will explain, you know, the tachometry and decelerations, accelerations, these stuff very well. Pretty sure, but I'm still early.
Just finishing chapter 1.
Yeah, you told me that you just started a month ago.
Mhm.
So you're just kicking off, man.
Yeah. But hopefully I'll do my best. Inshallah.
And wishing you all the best.
Thank you so much. Do you have any more advice for OB-GYN?
OBGYN,
Yeah.
just solving, and I repeat again, if that's your case, that you haven't had any background foundation, then I'd recommend a comprehensive source for you.
Okay. That's all I'll do.
Because I don't have much advice for OBGYN specifically. You know what I mean?
Yeah.
I would say advice for the whole step 2 thing. Like there was one who was typing in the chat who was saying he wants to take step 2 before step 1.
Mm-hmm.
And I'm totally against this idea.
Same. I'm against it too.
But I believe like step 1 is pass or fail, so you gotta go it's like a trial. You gotta go, you gotta see the material, you gotta just figure out how you would do in the board exams. You know, that it's a whole new different level of questions, ideas. But risking it with kicking off with step 2, it's kind of, man, it has a score. It will really affect you in the match process, I believe.
Of course it will. What time do you sleep?
Like today I'm just chilling after I'm done with my exam, but normally I sleep at 11
p.m. Mm-hmm.
11 p.m. yeah.
يبقى تعالى say hi.
Yeah, for sure. You told me that you will be streaming every day, right?
Yeah, every day inshallah. Like the entire day. Till I take the exam.
You're gonna document your
inshallah.
step 2 journey.
Mm-hmm.
All right, man.
What's your real name?
I
forgot to ask.
I'll end the. My name is Yusuf, but you can call me Joe.
Joe.
Yeah.
Okay. I'll call you Joe. Joe, programming for life.
Yeah. By the way, which medical school you were in back in Egypt?
Alexandria. What about you?
Ain Shams.
Ain Shams? Oh, nice. You say good things about it.
Yeah. Yeah. Yeah, it's kind of like I told you, the whole clinical content that I took back in year 4, 5, 6, it really helped me in the step.
Makes sense, yeah.
Preparation, even in step 1, in step 1, like I just for step 1, I just dove into Sketchy, and it was like super easy. Like in Pathoma, I feel like just reviewing the info, like nothing was brand new. And in Biochem, like the main bulks of step. And I believe with the new medical system, which is 5+2, that people are taking systems now, so I think that will be the best for step 1. Because back in the day, we didn't take systems. So when I was studying step 1, like taking renal or endocrine or something like that, I just like feel that's brand new. Like I used to take them as separate subjects. You understand me? Yeah.
Okay.
So I believe step 1 is easier right now with the pass or fail concept.
Of course, it's easy, very easy now.
Yeah, kind of so much relief right now.
Yeah, good for you, man. Hopefully we'll get rid of that step 3 soon. Let me know how, like, what do you plan? What do you plan on doing?
Yeah, I was talking with you about step 3, but step 3, I want to match into orthopedic, but I also have connections with some of my residents in radiology.
Radiology? It's competitive.
I have radiology. Yeah. Interventional. You're speaking about the normal diagnostic radiology or interventional one?
I think intervention is the more competitive one.
Yeah, it's like I believe that it's replacing cardiothoracic in a way. Like
Yeah.
I've heard from a fellow resident who told me that interventional radiology is now one of the most competitive. But it's a branch from radiology, so you have to match into radiology first in order to specialize
Really?
into yeah. So that's what makes the whole radiology specialty so competitive.
Just like plastics, I guess.
And in my case,
or no,
yes,
not
plastic, orthopedic,
yeah.
Euro. This is a top tier.
Oh, not plastic. Dermatology. You have to match into prelim dermatology, I think. You have to double match.
I don't see myself even matching into derma or ophthalmology. I don't see myself in those specialties.
Yeah.
I told you I want to match into orthopedic, but I saw the statistics of. I don't want to mean to like give you like. You know,
I know, man. I know. It's very hard for IMGs to match ortho. I mean, every USMD, I have a student, I have a friend who's like in Buffalo University. Like he's telling me like everybody wants to go to orthopedics. So
I see most people want to match surgery here in the US because of they say like surgeries are the highest paying specialties and you can see, and even on the media, if you see TikToks or Twitter or that, you'll see like surgeons, they have that lifestyle that
exactly. You don't know that they are
mostly neurosurgeons, by the way.
They are the most people that work, actually, surgeons.
Yeah, but I see like surgery is, you can't maintain a work-life balance. But it is what it is.
As a resident,
I like specialty.
After residency, like in
as a resident,
yeah. No way. Yeah. You just do.
But you gotta be on call. So you're always on call, especially when you're a general surgeon. So I believe like I want to match into orthopedic or radiology. But if I'm matching into radiology, I won't take step 3. I'd see it would be a waste of effort, to be honest. Because in terms of radiology, step 3 is just, there are some programs who step 3 plays like the role of a differential between you and the applicant. It's not the same as the same importance as step 2 or step 2 score or research. Research is a must if you want to apply for orthopedic.
Of course, yeah. At least 3 years, I think, right? Or 2 years?
Yeah. So I don't want to rush into the match process, right?
Yeah. Understandable.
Also, in comparison with the stats, so let's see, let's give it 1 more year to do some, or 2 years to do some research, gain some letters of recommendation, and then to be good to go.
Did you get any research position yet, or you haven't applied?
No, just finished step 2, so.
Okay, yeah.
I've done an elective.
Take some time.
Back when I was at medical.
Take some time.
I did some elective back when I was.
What are you planning to do?
For fun. What am I planning to do?
For fun, yeah. Celebration.
For fun. Yo, I'm an NBA fan, basically. I'll go to watch.
You told me.
NBA.
NBA
I told
too?
you I had an exam.
WWE. Yeah.
I had an exam today, and in 3 days, I was at Philly, man. So I really don't like to stress myself the days before the exam because it's already hella stressful. So
yeah, it's already done. You just gotta chill the day before.
Like the day before the exam, I rarely studied. I woke up at 6 a.m. I'm speaking about step 1, not step 2.
Yeah.
Step 1, I did a U-word block, I believe. It's a mixed block. And then I like I took the rest of the day for chill, and I drove myself to the test center. So I wanted to make sure that I'm familiar with everything, the sites. I think that's things that everyone should do. Step one
Yeah.
or step two, every night before any exam. That's my advice.
Yeah.
You could disagree with me. Some people like to review the high yield stuff the day before the exam,
Like
but
I took the
feel like
last 2 days completely off, like the 2 days before the exam. I think I just took the 120 the day before. That's it.
you know what? If I be honest with you, I've been watching you for 2 years. I told you that, but I never thought that I would be talking to you one day.
Bro,
To be honest,
come on, that's my pleasure. I'm very glad that.
Yeah.
Did you watch like all the
You
videos?
did. You did. I watched your videos, but there was a time that you took a gap from YouTube, I believe, or I don't know. I didn't know, but then I saw you come back with streaming. I saw you streaming every day. So that time I was preparing for my step, so I didn't attend your lives that much.
Oh yeah.
So after I'm done, now I'm gonna see you more. Now I'm seeing you. Now I enrolled into your Discord, so
Yeah, bro.
I'm getting to know you more.
I'll be very happy. It's such a pleasure. And good job on that step too. Hopefully, inshallah, I'll get a high score.
But you told me that you take the exam in August, right?
Hopefully, yeah. Like, I haven't scheduled it yet, but hopefully in August, yeah.
Don't schedule it until you solve like at least 3 NBMEs.
Yeah, of course.
You know what I'm saying? Just
like I told you, I have to get like at least one question bank done before even doing like the real question banks like Amboss and New World. So
yeah. But I want to know what material are you using, like books, in terms of books, not videos.
not at all. I'm not
Like-
using any books at all. I never used books. Like I hate using books. I just do the
Even I
step
saw
one.
in one of your videos you said, "Don't worship first aid."
Yeah,
Is there something like hate towards the first aid, or
yeah. I hate books so much. Like I like doing questions. I like doing
Yeah, but-
flashcards.
like you need to? But Anki, you use Anki?
I use Anki, yeah, sometimes. Like not religiously though.
Yeah, but make sure you are using it properly, because most thing with all medical students that some people don't use Anki properly. You know what I'm saying?
Yeah.
Like some people are just wasting their time on Anki.
Mhm.
Like Anki is like a double coin, two faces for a coin. It can be
Correct.
like very useful. Like I'm a guy that I rely heavily on memorizing. I won't lie to you.
Mhm.
So
I'm the opposite
Anki,
of you actually.
this active recall method. Yeah, the active recall method it kind of works for me, but I didn't use Anki that much
Mhm.
because I didn't find pre-made decks online, so I found like if I did flashcards, it would be a hell waste of time.
Mhm.
So I did BMEs, Born and Beyond, Pathoma, Sketchy, First Aid. Back when I was in medical school, some people advised me to use comprehensive resources, but I was kind of in a hurry. I want to finish it before year 5 or 6
Mhm.
because I want to do an elective. So I can't you can apply to an elective here in the US without step 1, but your chances will be like
Right.
hella low.
Yeah.
And
Right.
you gotta pay for the whole elective. It will be on your expense.
Correct.
You know what I'm saying?
Yeah.
So I said that step 1 would be better. And back in my time, it wasn't pass or fail. Like it was with score.
Mhm.
That's why I'm telling you that now step one is hella much better.
I agree.
So, why are you solving Board and Beyond? Kaplan QBank before you World? Like,
First of all, it's cheaper. It's very cheap. 3 months was like $160. Second, Yusuf Thomas told me it's good. So it's good as the first QBank. So, you know, I don't have to worry about my scores and stuff. Like, see my scores.
yeah, is it easier than UWorld or?
Not easier. No. I think it's harder. Look, so I got 70% on my first block, like random, 60-second.
But I kind of like your strategy in solving QBanks. Like,
what do you mean by
like
my
it's
strategy?
kind of good. Strategy, like you read what the question wants first before even reading the case. You understand? Like,
yeah.
most step 2 questions will ask you what is the possible step, what's the best next step for this patient.
Yeah.
As you said, it's all about guidelines and stuff like that. Mainly in OBGYN.
Correct.
And pediatrics. It's all about guidelines.
Mm-hmm. I hope I can see you one day, bro.
You said you live in Buffalo, right?
Buffalo, yeah.
Buffalo is kind of far from Tennessee.
Who knows? Maybe you'll match here. I'll match in Nashville. You know, who knows?
But I've never been to New York before. I told you I've been to Manhattan.
Yeah.
Like it's a destiny where like everyone in the U.S. when he first lands in the U.S. he goes to, but he really didn't like it that much.
Yeah. Do you have Instagram?
I have an Instagram.
What's your Instagram?
I will type it on the chat or.
Yeah, just tell me. I'll look it up right now.
Tell me what's your. Can you type your username here, or I will follow you?
Yeah, sure. Let me send it to your direct message. I gotta finish that. I don't know. I really want to sleep right now, but I got coffee, so I think I just have to use it. Let me get my phone. I don't know where my phone is.
All right, I will follow you. Is it Yassine _ Assam _ Ali?
Yeah, that's it.
Yeah. Well, I dropped you a follow.
Okay, I'll follow you back.
All right. So, what are your plans for the rest of the night? Or
So I got some coffee, so I have to use it, I guess. There's no way I'm gonna sleep right now.
yeah. And you're gonna stream tomorrow, right?
Yeah, inshallah, every day. Come say hi.
Okay. Yeah, sure. When do you start streaming? Or
The moment I wake up, I'll just go live.
do you stay live for a certain duration, or
No, just whenever I'm studying, I'm just gonna stream. Every single minute I'm studying, I'm gonna stream. If I'm not streaming, I'm not studying, you know?
then you're not studying yet?
Yeah.
By the way, how is it going with the step 1 course you told me?
It's going good.
Oh.
It's going good. I haven't finished the first round yet, so I still have some subjects I have to teach the students. But other than
does
that, yeah.
does it distract you from step 2, or
Does it
you
what?
organize your day?
Actually, I'm behind the course a little bit, so I'm supposed to be teaching them some stuff, but like I'm behind it actually in the schedule, but they understand my my situation and yeah. I'm doing like a new website.
Yes.
I have a new website where I'm trying to make the step 1 preparation.
You're doing.
Yeah, I have a new website coming. I'm trying to make step 1 preparation like step by step. So, you know, do this, do this, do this, do this. Not random stuff. So, yeah.
Nice. But you called it like a web designer to do the website for you, or you just
Yeah, a web designer. Yeah.
you kind of do it?
Yeah.
Yeah.
I would have probably
Okay.
told you about it if I knew you before that. You might have.
Yeah, but I'm not a web developer. I was teaching on my YouTube channel.
You have a YouTube
that,
channel?
that I'm coming.
Where is it?